on integrating nutrition in care, imperative to European citizens' health. It is a great pleasure to welcome everybody here. I hope you will have a great time. And I would first like to welcome Docent Bohuslav Svoboda, Associate Professor of Gynecology, and after him, Docent František Novák, Associate Professor of Internal Medicine. Docent Svoboda is the chairman of the Committee for Healthcare of the Czech Chamber of Deputies. He's the former and maybe future mayor of Prague. From 2013 to 2010, he was the dean of the Third Faculty of Medicine at the Charles University in Prague, and currently he's the head of Department of Gynecology at the Central Military Hospital in Prague. Mr. Svoboda, the floor is yours. Thank you.
Mr. Chairman, thanks for introduction. Ladies and gentlemen, all participants of International Congress of Integrating Nutrition Care. I am glad that leading nutrition experts and patient representatives as well will give a speech today. Nutritional care is an integral part of care to reduce morbidity, to reduce complication of treatment, to improve quality of life. I would like to thank for organization and participation such an important event. Unfortunately, I haven't stayed here because we are in Prague after election and now start discussion between elected members. I must be there. It's for me better will be here, but it's impossible. I wish you a pleasant day and successful meeting. Good day.
Thank you very much. And now it is my pleasure to welcome Docent František Novák, Associate Professor of Internal Medicine, Scientific Secretary at the Czech Society for Clinical Nutrition and Intensive Metabolic Care, member of the Supervisory Board of Alliance for Nutritional Care. Currently, an Associate Professor of the Department of Medicine at the First Faculty of Medicine at Charles University in Prague, and Head of Nutrition Center, Department of Medicine with the General Faculty Hospital in Prague. Thank you, and the floor is yours.
So, hello everyone. It's great pleasure to speak here on Czech ONCA team. So all participants and all guests, Czech ONCA team actually called, or the organization is named Czech Alliance of Nutrition Care. Started its work as a part of Optimal Nutritional Care for All, which was launched by European Nutrition for Health Alliance in 2014. As a matter of fact, this history started much earlier, the campaign Fight Against a Burden of Disease-Related Malnutrition. And as it went on, things were proven to be much more complex. So this campaign was started to help member countries, which are now 19, including Czech Republic. In 2014, Czech Republic joined first as a guest member or observer country year after, and became a full member in 2016. As inspired by European Nutrition for Health Alliance, we were able to found this Czech Alliance of Nutrition Care as a similar multi-stakeholder organization, joining together dietitians, physician nutritionists, but also politicians, patient organizations, and also pharma industry providing means of artificial nutrition. So here to present objectives of Czech ONCA as complex nutrition care consists of full-scale nutritional risk screening, which is, of course, first step to effectively find those in nutrition risk and those malnourished who are diagnosed by proper nutritional status assessment. But true is that without proper intervention in those found at risk or malnourished, it has no impact. So screening, first step, proper assessment, and timely managed nutritional intervention is the key for cost-effective nutritional care. Nutritional care in this manner is found or has been found and has been proven as one of the most effective health interventions we have among our tools. Also, logistically, to organize such a care, we need to have proper reimbursement, and thanks to Czech initiatives, also home enteral and parenteral nutrition is fully reimbursed in the Czech Republic. Also, in the last several years, we are trying to get also out of hospital care to primary care, to general public, as we know that nutrition is related to general health, and in such a manner, everybody is involved or should be interested in nutrition throughout the whole life cycle. So, again, welcome everybody in this seminar. Here are seminar objectives. We have gathered esteemed speakers from various stakeholder environments. Today we will hear a patient perspective, but also expert nutritionist, oncologist perspective, as a part of Czech EU presidency. Is important campaign fight against malnutrition in oncological patients. So another great area of importance in nutritional care is elderly care and people who or elderly people who live also outside these care facilities must be looked after by mostly dietitians. Dietitian is a key healthcare worker who is supposed to look after nutritional status, and we will show you the initiatives how to empower the role of dietitian in healthcare system. So we will try to summarize three key important things as change in DRG system of reimbursement in hospitals, also appropriate tailoring of nutrition care system of reimbursement also in outpatient environment, and thanks to European ONCA, we invited esteemed guests also with respect to discovering the possibility to use human rights approach in nutritional care, just to use it as a tool for local implementation. So this is all from me to introduce, and thank you again for your participation. And I hope you will enjoy the whole seminar.
Thank you very much. I think we've heard a lot of interesting thoughts that we'll have a possibility to discuss later in the panel discussion. And right now, I would like to ask Ms. Monika Malíčková, a patient with her presentation on a patient's unmet nutritional needs. Ms. Malíčková is Vice President of the patient organization Life Without Intestine, member of the Czech Association for Rare Diseases, member of Czech delegations at ONCA conferences. Her motto is, "We can't always improve health, but we can always improve life." Thank you. The floor is yours.
Good morning, ladies and gentlemen. My name is Monika Malíčková, and I'm here to talk to you as a patient and also on behalf of our Czech National Association, Život bez střeva. Let me please introduce our association just briefly. Život bez střeva could also be translated as life without intestine. It is the Czech National Association for Adult and Children Patients on Home Parental Nutrition, shortly HPN, and it was founded in 2008. In the Czech Republic, there are approximately 500 patients using HPN. This number changes, obviously, because it includes patients that use HPN temporarily, short-term, but also long-term or permanently. We are a small group of 29 members, but we also have about 200 website followers. Our main objectives are to support patients on HPN and to improve their quality of life. We also like to raise public awareness, and we join the World Home Artificial Nutrition Day every year, which is on the 15th of October. Our association is a member of ČAVO, which is the Czech Association for Rare Diseases. That's because among us we have patients who suffer from a rare disease which requires them to be on parental nutrition. And we are also a member of PASIFAN, which is the International Alliance of Patient Organizations for Chronic Intestinal Failure and Home Artificial Nutrition. Now, I would like to shortly introduce you to home artificial nutrition. It is a type of nutrition that is made up of two parts. One is enteral nutrition, also known as tube feeding. You might have heard about it, where the body gets its nutrition through a tube that is inserted either into a nose or directly to a stomach or to a small intestine. And then there is parenteral nutrition, which is a common infusion or drip. Home parenteral nutrition is the last resort of eating. I have the eating there in parentheses because it's a special type of eating. Actually, we provide the body with nutrients and hydration while bypassing the digestive system completely. The nutrition gets into a person's body through a central venous catheter. Now, the reasons why people might be on home parenteral nutrition is commonly known as short bowel syndrome. This condition means that it could be either physiological or functional damage to the digestive system. In other words, the person is either missing parts of intestine, so the body cannot get enough nutrients, or the intestine is there, but it's not functioning properly. What could happen is that children might be born with defects to their digestive system, and they are dependent on parenteral nutrition from birth. But a person can also acquire damage to their digestive system throughout the life. Very often it's as a consequence of various illnesses and diseases or treatments. The patients very often have Crohn's disease, ulcerative colitis, some of the rare diseases, as I mentioned before, or as a consequence of aggressive treatments such as radiotherapy or chemotherapy, which may cause damage to the digestive system. And also there are various accidents and traumas to the abdomen, which may result in losing parts of the abdominal organs and the need to have home parental nutrition. Now let's have a look, at least briefly, on some of the patient needs. I also have experience internationally talking to patients, so I know that the patients are facing same or similar problems, or they have same or similar needs all over the world. So the list that you see here could quite easily be converted into international needs. And I would also like to say that it's not final. It can always be extended. And it's not in any particular order either. That's because we can have a look at this list from various points of view. We may ask about the importance or the satisfaction. In other words, asking a patient how important it is to them, the service or support that they have, or how satisfied they are with the current level of service and support. As I said, there is no particular order, but very often these needs overlap and they are also interconnected. So if I just maybe start with joined up thinking with other diseases. Now, often patients have more than one disease that is related to their need to have home parental nutrition. And it's important that doctors who take care of a patient, they talk to each other in terms of what the patient needs from the nutritional point of view, and also how they treat their primary or underlying illness. And that relates to the need to have multidisciplinary team, for example. That comes from the fact that a patient with short bowel syndrome may need other specialists or other doctors in his team. So not just gastroenterologist, for example, but they also need a dietitian, nutritionist, sometimes physiotherapist or psychologist, or if they suffer from other disease, rare disease, they need a specialist that understands their rare disease. And it is important that all these people talk to each other. And that brings me to the need for the centers of parental nutrition to cooperate together, because we might have 2 or more patients that are in the same or similar position, but they might be living on in different parts of the country. So it's vital that the specialists talk to each other and they exchange information about these patients so they can give the patient the best care possible. Maybe on this side you will see better some of the needs. I picked these 3. As I said, there is no particular order, but I feel and the patients feel that, for example, the equity of care and access to equipment and services is still not same for all. It very much depends which region you live in or which hospital you belong to. Based on that, it's not common, or shall I say, it's not automatic that you would be offered the best equipment available or the best ancillaries or the best accessories you might need for the treatment. Socializing and interacting with others is very important too, and it's again related with the equity of care and access to equipment. Parental nutrition is a treatment that brings about a lot of social isolation, loneliness, and it can feel as a big psychological burden. Because when you need to infuse instead of eat food orally, you spend a lot of time on infusion. And it puts really big strength on the way you think about life. Also, having the best equipment and services is very important for the healthy development of child's personality. Now, we need kids to go to school, although they might need parental nutrition. We need adults to have opportunities to work if their health allows them, of course. And all the patients need opportunity to practice their hobbies, enjoy culture, social or family events as well. And all this, again, links to cooperation between centers and the coordinated care, because for the patients, it is important that doctors speak to each other and they collaborate, they exchange information. It would be nice if the centers would be able to cooperate on international level as well. In this case, we can nicely demonstrate the overlap going from national needs to international needs. If we have the centers collaborating on internationally, then we might be able to allow patients access to centers all over the world, which in turn would enable patients to travel more freely. Because it gives us patients a bigger peace of mind, knowing that if I go somewhere, I have somewhere to turn to should I need somebody's help. Having said all this, I think that everything goes into fulfilling the ultimate need of each chronically ill patient, and that is to give them the best quality of life possible. So please let me share with you an example of good practice of how to fulfill patients' need. As I said, I'm a patient myself, and on this slide you can see in the first photo here, yeah, that's me. In 2011, I suffered sudden abdominal catastrophe, which resulted in removing the whole of small intestine and spleen, and later on I also lost a third of colon. Now, having spent a few months in the hospital, I was sent home with a pump on a pole, and I was told that from now on I need artificial nutrition, and that I need to infuse 16 hours a day, every day, for the rest of my life. Now, when I sat down, then I thought, well, that's 2/3 of my life, which I will have to spend in the house, because with this type of pump and with this type of equipment, it's impossible to have a normal life. So I had to stay at home. I was confined to my home from 4 o'clock in the afternoon till 8 o'clock in the morning. So the need for a mobile pump was extreme. I think here we can quite nicely demonstrate the psychological burden that the patients have and they have to deal with. Anyway, we did, for me, a bit of a miracle, and we managed to put together doctors and an industry partner and also governmental bodies and policymakers. And we got mobile pump into the Czech Republic. So the 1st of January 2015, the first ambulatory pumps became available for patients in the Czech Republic. And since then, I can now live my life after 4 o'clock in the afternoon as well, which is quite nice and a big change. I would like to share with you a few more stories. If you have a look at these two boys, they both are dependent on HBN. They have been dependent since their childhood. And as you can see, parents were desperate to get kids out, although getting them out with this kind of equipment, it requires a lot of will from the parents. Anyway, these two boys now can go to school as well because they can put the infusion and the pump into the backpack and they can go to school. The mobile pump actually came around just in time where their parents were considering what to do with the kids, what to do with the education, because getting them to a normal, usual school was proving to be very difficult. Now their life changed again. They are still dependent on parental nutrition, but at least they can go out. I think my main message is I believe that we can fulfill the patient's needs and we can improve their life if we put these three worlds together. If we put together patients and the carers, which are usually parents of small children patients, the medical professionals, doctors, physicians and nurses, and join them up with industry and policymakers, governmental bodies, and so forth. This way, we can bring about much-needed change, and we can improve the life of many, many people. Ladies and gentlemen, thank you very much for your attention. And please, as we said at the beginning, remember that maybe you or we cannot change health of somebody, but we can always improve their lives. Thank you very much, and I wish you a very good and productive meeting. Bye-bye.
Thank you, Mrs. Maličková, for your inspiring presentation. Next, I would like to invite Professor Alessandro Laviano, an associate professor at Internal Medicine, who will be having a keynote on integrating nutrition into cancer care. What does science say? Professor Laviano is coordinator of the supervisory board at the ESPEN project on Nutrition Day. He's the expert reviewer for the framework programs of the European Commission. From 2010 to 2014, he was the chairman of Educational and Clinical Practice Committee of the ESPEN. As for his professional appointments, he's associate professor of internal medicine at the Università Sapienza in Rome, head of the clinical nutrition unit. His scientific focus is on the role of brain activity in pathogenesis of cancer anorexia and cachexia?
Cachexia, yeah.
Almost there. At integration of pharmacologic and nutritional approach to cancer patients. He published more than 180 publications in internationally peer-reviewed journals. Mr. Professor, it's a pleasure to having you here. Thank you, and the floor is yours.
Well, thank you. Thank you very much for your presentation. And maybe my short CV is longer than my talk. Anyway, sorry for that. First of all, I would like to thank the ONCA Czech team, the Ministry of Health, and all the people who actually worked to set up this meeting. The topic I have to address is why nutrition is important in patients with cancer. Of course, these are my disclosures, these are my commitments with the industry, which could be perceived as a conflict of interest. And usually you don't start a talk by quoting someone else. But I would like to change this way of thinking, and I would like to start quoting William Osler. You know, William Osler is the founder of North American medicine. And he was saying that the good physician treats the disease, but the great physician treats the patient who has the disease. This is a major point that we have to discuss, because during the last decades, our healthcare systems has moved to a sick care system. So they are mostly focusing on the disease and not really on the patients with the disease. This is particularly important in patients with the cancer. And it is so true that 5 months ago, in this very, very top journal, Nature Medicine, a group of researchers, clinicians, but also CEO of big pharma industry were saying, hey, you know what? Cancer treatment should benefit the patients. Because again, still now there are many approved cancer therapeutics which are offering limited clinical benefits, and yet we are still prescribing to the patients. So let me give you some example of that. For example, let's look at the most recent trials on new drugs for patients with cancer. For example, out of, you see here, 17 trials showing an improvement in overall survival, the majority were not showing an improvement in quality of life. Out of 27 trials showing an improvement in progression-free survival, 17 showed no difference in quality of life, and 4 actually said, well, the quality of life went down. So I think this is very important that we have to remember, and we always have to remember that because of that, particularly in Europe and in other countries, so-called the high developed social demographic index countries, well, cancer is the first disease which has the greater burden in terms of daily. What is daily? Daily is disability adjusted life years. What is daily? It means that is a gross estimation not only of the years of life lost because the patients die, but also the number of years the patient live with disability. If you want to translate this information, this graph, into a statement, it means that cancer not only kills, but also those who are not killed by cancer, they are living with disability. So I think it's important that we focus on the needs of the patients. Are we doing that? Not really. This is a recent study showing that during the last 30 years, the trials addressing the so-called patient-reported outcomes. So saying we are testing this approach because we want to see if we can improve something that the patients care the most, well, did not improve. You see here, they did not improve at all over the last 30 years as the primary endpoint. So again, there is some kind of blindness on the needs of the patients. So let's see what we can do. Well, of course, you know better than me that if you have a patient with cancer, he or she has to receive 2 types of treatments. The so-called disease-modifying therapies, which address the vulnerabilities of cancer cells, but also has to receive supportive care, whose main aim is to improve the quality of life of the patients. And as I said to you before, there is a lot of interest and a lot of economic efforts to improve these disease-modifying therapies, but there is less interest in the supportive care, which of course includes nutrition for the patients. Now, how are we good in treating the cancer patients? Well, of course, yes. These are North American data, quite recent data, showing that over the last 50 years, there has been a drop in mortality rate of approximately 25%, which is a major outcome. Although we have to remember that most of this improvement is because now we are diagnosing patients at an earlier stage, so it's easier to provide a longer life expectancy. However, there are also other types of tumor which have not been improved in terms of rate of mortality, including pancreas, brain, and esophagus. The same proportion of patients was dying in 1971. The same exact proportion of patients with these three types of cancer are dying now. So there is still room of improvement to enhance the efficacy of anti-cancer treatments. There is another big challenge that politicians have to take care of, that we expect in the next 50 years a huge increase in the number of new cancer cases. Of course, the majority of these increase will be in the countries with low or medium or high developing index. However, even in Europe, which is an area, geographic area with a very high human development index, we expect a 40% increase in the number of cancer. Are we prepared for that? I'm not sure about that. I'm not sure we have the money to actually withstand this challenge if we only focus on drugs. Why I'm saying that? Again, evidence. Nice study looking at the new drug approvals by FDA over a period of 5 to 6 years. And you see that only 15% of the new drugs are the so-called displacing drugs. So they are really a major breakthrough. You use these, you don't use anymore the drugs you have been used until now. But the vast majority are actually add-on. So the number of drugs we are going to use are much larger, which means a huge increase in the cost because, again, we don't have first-line displacing drugs. We don't have drugs who says, okay, now we use that, we cannot use all the ones we were using years ago. So what do we need? We do need a moonshot, like the Americans are doing, or we need something else. Well, Europe is different from America, much different. So it's much more important that in Europe, as said in this nice editorial published in the Lancet Oncology a few years ago, we maybe don't need a moonshot. We don't really need a technocratic approach to the disease, but we need a more patient-centered approach to the patients in order to address the needs of the patients. Now, how can we do it? How nutrition and supportive care can help on that? Again, I told you that the main goal of supportive care, which includes nutrition, physical activity, psychological support, pain control, has the main objective to improve quality of life. However, I will show you that if you address the needs of the patients, also actually the efficacy of anti-cancer drugs is enhanced and improved. First of all, is malnutrition a problem? Of course, yes. These are Italian data showing that on their first oncological visit, approximately 50% of the patients are either malnourished or at a high risk of malnutrition. So from the clinical standpoint, malnutrition is a clinically relevant issue. But not only that, we know that malnutrition is associated with a poor outcome. This is only one of the hundreds of studies showing that changes in body weight, changes in body composition, changes in the quality of muscle mass, like in this case, is associated with a worsening of the survival of these patients. And another important aspect, even withstanding this, the interest of physicians on patients with malnutrition is very, very low. You see here, this is, again, a recent study showing that over 30 years, the proportion of patients with a BMI lower than 18.5 in clinical trials is progressively declining. Okay, you may say, well, it's of course, we don't see in Europe, in North America, many patients who has a BMI lower than 18.5, so it could be. But using BMI to find eligibility for a patient is a major error. Why I'm saying that? Because of these very recent studies showing that if your patient, when you diagnose him with cancer, has a BMI as a normal BMI, you have to look at what happens before, and you see that as an average, all patients with cancer, they have approximately a 2 to 4% weight loss in the previous month. And more importantly, see here, the patients with cachexia, so disease-associated malnutrition, they have in the month before up to 10% weight loss, non-volitional weight loss, which means that using BMI to say this patient should be included in a trial or not included is a major error, which may create a bias in the result that we obtain. There is another important aspect. We already know that early supportive care is associated with a better outcome for these patients at a fraction of the cost for new drugs or new treatments. Again, this is an American study showing that if you support your patient with supportive care early in their clinical journey, you will see a significant improvement in the clinical outcome. And we also have good evidence showing that if you intervene early with specific nutrients, like in this case, omega-3 enriched oral nutritional supplements, again, you have an improvement in quality of life of these patients. Now, do we have strong data? Well, because of this study, which was published last year, which comes from a large Swiss study in hospitals, we see that an early individualized nutritional support in patients at risk of malnutrition and with cancer is associated with an improvement in functional outcome, particularly a reduction in the decline in functional status, and also an improvement in the quality of life as measured by the EQ5D, which is a validated tool to assess quality of life. However, this is not important. This is important. If the patient is early treated for malnutrition or for a risk of malnutrition, they also have, as you can see here, an improvement in survival. Okay, you may say, well, this should be 6%, 7% improvement in survival. But you know better than me that there are many drugs which have been approved and you are paying with your taxes, which have been approved because of an improvement of 5%, 6% in survival. So this is a major outcome because it came without drugs, but only with early nutritional intervention. Not only that, it's very cheap. It's a cheap control because you see that these results could be obtained by maybe increasing calorie intake by approximately 5 kilocalories per kilo per day, and protein intake by increasing 0.2 to 0.8 gram per kilo body weight per day. So basically you have this approach, these results with an investment of approximately 5 euros a day, 6 euros a day, something like that. Anyway, it's important also to remember that these results could be obtained not only with these, I would say, more fashionable nutrients like omega-3 fatty acids, lipids, and so on, but also a very stupid nutrient like fiber can make a difference. This is a study published in Science showing that if your patients eat enough fibers in their diet, approximately 20 grams, they have a better outcome when they receive immune therapy for melanoma. Again, maybe a 2 euros intervention a day, and you have, as you can see here, a major improvement in overall survival. Again, these are data, this is evidence published in high respected journals. There is another major aspect that we always forget. Cancer is now, I would say, a chronic disease. And so far, we are only focusing on the so-called catabolic crisis. So we are focusing, okay, nutrition should go here because the patients, because of chemotherapy, are becoming dysphagic or with anorexia, with diarrhea. So we have to focus on these catabolic crises, on surgery. Please remember that nutrition is a continuum. So all the patients should receive information, recommendation on how they should receive or should implement nutritional guidelines in their whole life. It's a long-time journey, and they will receive a chronic nutritional intervention. Why I'm saying that? Again, because the evidence is telling us that it has an impact on outcome. This is an American study. The research question was, what happens to patients who are diagnosed with the colorectal cancer if they increase the intake with the diet of omega-3 polyunsaturated fatty acid? What happens in terms of survival? Again, you see here nicely that those who increased after diagnosis the most the intake of omega-3 fatty acids are also those who has a significant reduction in colorectal cancer-specific mortality. Again, showing that we have to focus our attention not only on the patients who are receiving anti-cancer treatment, but we have to focus our attention from the day of diagnosis until the day the patient is cured, or unfortunately, he's not any longer on this planet. Having said that, how can we summarize? Okay, which are the current and future challenges? Which could be potential solutions? First of all, I think it's important that we focus on early diagnosis. If I have a €1 and I have to make a bet, I think that early diagnosis should be really the future. So liquid biopsies, I think this is the real most important area of scientific and technical research. However, we also have to work on eligibility of our patients. We need to understand which are the factors, including body compositions, in order to say, you deserve this type of treatment. Because of your nutritional status, we know that you can start the treatment schedule and you can finish your treatment schedule. Another important aspect is effective therapies, trying to develop more effective therapies. It's not easy, of course, because I told you before that unfortunately cancer cells have a very, very high flexibility, so they can change very rapidly. And in some cases, well, this has been demonstrated in patients with breast cancer, the cancer clones of a breast cancer completely change over some years. So the type of tumor a lady has after 3 years is biochemically completely different from the one which was diagnosed 2 or 3 years before. So the technical, scientific challenges of trying to find effective therapies for these patients is very, very high. Other important aspect, affordability. Can we afford these new drugs? Probably you know that there is a nice study published in the US showing that even if you have a salary of $100,000 a year, you can go bankruptcy if you are diagnosed with a cancer, even if you earn more than $100,000 a year, which means that the affordability of the treatments is important, particularly in Europe, to protect the national healthcare systems. And I want to highlight and stress that nutrition helps in that, because nutrition helps in assessing the eligibility of the patients. Nutrition helps because make therapies more effective, not because we are curing cancer with zucchini or banana or mango, but just because if we can protect the nutritional status, also the therapies are more effective. And regarding affordability, it's not an issue here, because I showed you before that with an intervention of maybe less than 5 to 6 euros a day, you can increase quality of life, you can improve survival of patients with cancer. So most of these discussions, most of these data are part of a discussion which is now occurring at the European level. There is a platform, an EU platform, which is the Integrated Nutrition Cancer Care, and because of these exchange of ideas, discussion between different professionals, and I liked very much the previous presentation regarding the interaction and discussion between different specialists, which can make the difference also in cancer care, not only in the patient with short bowel. So because of that, we came up with a white paper which we hopefully publish in an oncology journal, and this is because of the contribution of ESPEN, the IFAD, EASO, nurses, Lung Cancer Europe, the German Society of Clinical Nutrition, and the Association of the Students in Dietetics. So, how can we conclude? Well, I think the science has spoken, has said we have a problem, we have a solution. I think that the patient spoken. The patient said, we want treatments which benefit ourselves. We don't want to have an extended survival and maybe 10% of these more year of life is spent in hospital or is spent bedridden. The patients have spoken. Now, has the politics responded about that? I would like to give a humbly practical suggestion for the Czech health minister, saying that we have now the guidelines. We know what we should do. If you look at the ESMO guidelines, the ESPEN guidelines, the EONS recommendation, the IFAD recommendation, we know what we should do. But however, there is a gap between what we know we should do and what we are doing. So it's important that we focus on the implementation of these national, international recommendations and guidelines in the real world. And again, I want to end this presentation by quoting one of my favorite superheroes, which is Spider-Man. Please remember that with great power, like the power a politician has, comes great responsibility. Thank you very much for your attention.
Professor, thank you so much, and I would like to kindly ask you to stay with us for a few minutes. Could I ask
sorry.
you?
Oh, sorry. I'm so sorry.
No, thank you so much. It was really interesting, and I mean, you touched upon a lot of subjects, and you are, of course, active on the EU level. So, from the point of comparison, EU and USA, where do you think the differences lie, and how can we learn from each other? What is better where, and from the perspective? Or is it very similar in terms of...
Well, I think that Europe, I'm not saying that Europe is better than US or US is better than Europe. It's a different way of thinking. And definitely in the US, there is a great interest in this, I call the technocratic approach to the disease. And I fully agree that it is important that we know the biochemical pathways of cancer cells. Of course, it's extremely important, because if you can do it, then of course you can prevent all the consequences of cancer. On the other hand, we also know that this approach will last will deliver some results in 10 years, something like that, which means that there are millions of patients who have cancer now and should receive some kind of support for their disease. So in the US, there is this kind of work focusing on what would be better from the scientific point of view. I think that in Europe, we have to move our focus on what would be better for the patient. And there are patient coalition, patient association who can tell us, believe me, I don't care to live one more year if I have to spend 3 months in a hospital or bedridden. I want to have a nice life with a good quality of life.
Yeah. So it seems maybe that the way of life and the quality of life is more of a center of focus in the EU than in the US, where the focus is really on the efficiency and on spending the money to get the best result. Whereas
absolutely, but because it's a fault that of us doctors, we made the mistake and we said survival per se is the outcome. Because it's easy to measure. Okay, you see how many have died today. Okay. But it's difficult. It's not survival. It's survival and disability or better quality of life. And I think that from this point of view, we can be of help to our colleagues in the US.
Absolutely. And in terms of the EU, which country do you see as the most progressive in this sense? Well,
actually, there is very good approaches at the EU level. The The problem that I see, and I discuss many times with my friend Jost, is the fact that at the EU level, they say, okay, we understand the problem, we can develop a fantastic guidelines, recommendations, but then they stay in Brussels. And you need to work. I fully understand that there is now, from the political level, some kind of, okay, in my country, I know what is better for my patient. But I think that a patient in Italy or in Denmark or in Czech Republic or in Portugal, they have the same problem. So I would say that we need this kind of pressure for the EU on the national authorities saying, you have to do that. One very simple thing to do would be to say, the government gives money to national cancer system. Yes, of course, we give you 5% extra money if you take care of that.
Yeah, that's really.
I think it's very easy, very, very easy.
Yeah, well, that's really interesting. And in terms of, I mean, you are active in Italy. So do you see the pressure for this in Italy too? Or what are the priorities in that sense in Italy?
Well, absolutely, yes. But because now patients has realized that they have a voice in medical decisions. And so they say, you know what, I'm losing weight. And sometimes the patient said, well, but you are obese, so don't worry. But we know that an obese patient could be already malnourished. So it's important that the patient speak out and say, we want to have this, because so far, as a clinical nutrition unit in an academic hospital, we are receiving many cancer patients when already lost 10% or 15% of their body weight, which of course may reduce and minimize the efficacy of nutritional intervention.
Mm-hmm. And you mentioned patients. I'm also wondering, in terms of patient organizations and their overall organization in Italy, how strong are the patients or the associations? Because, for example, in the Czech Republic, the role of patient organizations has really improved, and they are very important in the reimbursement process, etc. How is it in Italy, and in terms of their voice?
Absolutely, there are many associations, and they are really making a big effort, and their voice is becoming listened by the policymakers because they vote. And I mean, there is nothing wrong, there is not ethically wrong in asking your policymaker, these are my requests, this is what I really need. Mm-hmm. It's nothing wrong to lobby, I mean, just to, speak out which are your needs.
Yeah, definitely. Thank you so much.
Thank you so much. Thank you. Thank you. Bye.
Perfect. Thank you so much. And now I would like to ask Docent Pavel Těšínský, an associate professor of internal medicine, who will be having a lecture on ONCA good practices, strategy and action plan to implement nutrition as an integral part of quality care in the Czech Republic. Docent Těšínský is the president of the Czech Society for Clinical Nutrition and Intensive Metabolic Care. He's the chairman of the Supervisory Board of Alliance for Nutritional Care. He's also the chairman of the Accreditation Board for Clinical Nutrition of the Czech Ministry of Health. As for his professional appointments, he is the head of Division of Intensive Care at the Clinical Nutrition and Metabolism at the Department of Medicine of the Faculty Hospital Královské Vinohrady. He's also an associate professor of internal medicine at the Third Faculty of Medicine, Charles University in Prague. Docent Těšínský, thank you so much for your lecture, and the floor is yours.
Thank you, Igor. Well, I think that it will be much better that I get my time for the presentation and not for the introduction. Well, but thank you so much. This is the outline of our today's presentation. We will talk about experience from the European ONCA initiative for our motivation, and then about the current status of nutritional care in my country. We'll talk about nutritional societies and organizations, about the system of education, and then about nutrition care in hospitals and in outpatient sphere. And I would like to conclude with what we have achieved, what we are working on, and what we learned from Europe, and if there is something what can we give Europe an action plan maybe for the future. By the way, I have no disclosures for my today's topic. 1983, Professor Simon Ellison published a study focused on hospital malnutrition, and he concluded that 30% of patients enter hospital with any signs of malnutrition, and about 40% of patients leave hospital malnourished. 1983. We have data from a Nutrition Day campaign. The last which have been published are from 2019. And I can tell you that a third, 30% of patients enter hospital malnourished, and up to 40% of patients leave the hospital malnourished. Well, it's plenty of time between the original study and our current data, and not much is different in terms of hospital malnutrition, despite of all the activities and all the focus on this problem. So the message from the Nutrition Day 2019 data can be summarized into 3 points, which are important for me, being active in my country, in Czech Republic. So, number one, there is a high level of nutritional risk among hospitalized patients. Number of geriatric patients with low BMI and a high proportion of patients with unintentional weight loss compared to the world. Then in Czech Republic there's a smaller number of doctors, or ratio of doctors, nurses and dietitians per patient. Again, in comparison with Europe. And patients are being discharged from the hospital care later than in other countries. And it is because of a simple fact that the system of transfer of the patient to home care is not working efficiently. We do not have enough facilities for elderly people, and therefore people stay longer in the hospital. It's not good for them, it's not good for the families, it's not good for the budget. So we have to work on it. It's always good to take advice or to take experience. And ONCA initiative is authority which may be useful for this purpose. So what we learned from the ONCA initiative is that it's essential to have a multidisciplinary national platform, an alliance or whatever you want, with a group of interests which are involved. Second, we need the authentic voice of patients, of their representatives, their organization. Without politics, we do not achieve anything. So we need politicians, we need the government, and especially the Ministry of Health. They are able to drive force at the national level and show the results on the international level. So if we are able to convince the politicians that nutrition, malnutrition, nutrition effectiveness, hospital care is an important topic, so they can work with this topic. So nutrition for the politicians. And public awareness. We have to work with the people. And we do already in the campaign Malnutrition Awareness Week, in Czech Týden rizik malnutrice, we published a lot of materials, and many of them are on social media, on the web, on Twitter, on the Facebook. And when people just open the file with Malnutrition Awareness Week in Czech, they are able to get information about malnutrition, how to diagnose malnutrition. They can evaluate a table with their risk of malnutrition, and they also get receipts how to work with a family member who is malnourished. They can get receipts for cooking, etc. And last but not least, we need data. Without data, nothing is possible. So we have to find and monitor indicators of quality of nutritional care as a measure of success, and by this way we are able to enforce reimbursement of necessary costs for hospitals and outpatient facilities. So, Alliance for Nutritional Care, in Czech APNP, is a multi-stakeholder non-profit organization which addresses nutritionists, the Czech Society for Clinical Nutrition and Intensive Metabolic Care, with a long tradition, dietitians. They have two organizations. This is Czech Association of Dietitians, as well as a section of dietitians of the Czech Association of Nurses. The voice of patients is necessary, and also the business, the industry, Association of Companies Focused on Clinical Nutrition. You can see some analogy with ESPEN, European Society for Parental and Enteral Nutrition, which cooperates with MNI, the medical nutrition providers. Education is the most valuable thing. Without education, you don't achieve anything. So the system of education is based on certification in clinical nutrition. This is a motivating aspect. In pre-graduate part of education, it's the inclusion of clinical nutrition into the educational program of medical faculties. In my opinion, we have still work on it. I do not find that we can be satisfied with number of lessons, seminars, lectures for pre-graduate students in terms of clinical nutrition. So this is our debt. This has to be worked on. For postgraduate education, it's, in my opinion, somewhat better. There is an accreditation board of the Czech Ministry of Health, and we have certification of hospitals for training doctors in clinical nutrition. This board also certifies qualification programs, and by this, after a particular education, a doctor, a physician may apply for a medical certification in the field of clinical nutrition, so he has a diploma. Historically, we have a so-called functional license. It has been initiated by the Chamber of Czech Physicians, and it entitles a doctor or qualifies a doctor to prescribe home parental and enteral nutrition. There is a developed educational program of medical faculties for dietitians for degree of bachelor and master degree. And last but not least, also a training program and certification of home care agencies for providing home parental nutrition. I'll just name one of them, Nutrica, which is a public non-profit service company for education. Now, how is it with nutrition care in hospitals? About 4 years ago, Ministry of Health addressed the Czech Society of Clinical Nutrition with the aim to innovate the guidelines for provision of nutrition in hospitals. And last year we succeeded to complete the guidelines, and this process was endorsed by the Czech Minister of Health. So the system of nutritional care is based on the screening, examination of nutritional status and nutritional therapy. And it's absolutely crucial that dietitians and nutritionists are those professions who are responsible, who guarantee the guidelines for provision of nutrition in hospitals. And the dietary system has been innovated and adapted in accordance with the ESPEN guidelines on hospital nutrition. Now, it has been published, and we are now in the process of implementation of the guidelines for provision of nutrition in hospitals. For this purpose, we are going to organize another survey questionnaire, which will be obtained next year with the help of Ministry of Health, and we use also the Nutrition Day data, because without control, without feedback, an implementation would not be complete. For purpose of the feedback, we need some support from the politician, from the insurance, and from the insurance companies. It's a cultivation of DRG codes and actualization of the role of dietitians. There are 2 points which are crucial for the sustaining and quality of nutritional care. In the ambulatory sphere, there is an existing network of outpatients offices which are guaranteed by nutritionists, so the holders either of the certification or functional license F016. But there's a long way to go from now. We need a better cooperation with the general practitioners. We need preparations of recommendation for nutritional screening and implementation of the guidelines for nutritional therapy in outpatients facilities, like long-term hospitals or senior houses and so on, and also for general practitioners and for outpatient specialists like oncologists, gastroenterologists, surgeons, and so on. We are able to support education of general practitioners and outpatient specialists in terms of accessibility of the license F016 for prescription nutrition for outpatients, and we are also prepared and able to give services of dietitians for outpatients. Unfortunately, reimbursement delivered by insurance companies is still not working. Even more, we are able to give evidence of cost effectiveness of nutritional therapy in the outpatient sphere. Malnutrition should be put as a public health agenda. So, first, early identification of patients with malnutrition and at-risk malnutrition using a DRG classification. But it is not enough. We have just one code for malnutrition, and it does not fit all. So we have to create and validate a new scoring system. We keep work on it. And we need to define a signal code to identify patients with malnutrition and at risk of malnutrition, because they are not visible in the system. So they do not deliver any feedback. By this way, we can monitor the effect of nutritional intervention of hospital malnutrition and evaluate the cost effectiveness and compare nutrition intervention or nutritionally intervened patients with the other group. So now let's conclude with the three last slides. What we achieved. So we achieved raising general awareness of the importance of preventing and treating malnutrition throughout society. Malnutrition Awareness Week, Nutrition Day, and many other activities. Then we created and introduced guidelines for nutritional care in hospitals. We are really proud of it, and I am happy that my co-authors are with me present in the auditorium. We introduced nationwide nutrition screening at all levels of health care, with the fact that in ambulatory outpatient care it still needs to be introduced. And also nutrition teams in hospitals are available in all hospitals which are directed by the Czech Ministry of Health. It's a big progress. And we have, I think, a good working system of continuous education of health professionals, which is focused on the problems of clinical nutrition. What we are working on. I really appreciate cooperation with the Ministry of Health and with health insurance companies. This cooperation is absolutely crucial and needed for implementation of the guidelines. This is a matter of Ministry of Health and our cooperation and evaluation of their effectiveness. I'm sure about it, but we need data. But what we need is to change of reporting of provided nutritional care to health or toward health insurance companies, because, as I already stated, the nutritional care is currently not recognizable in the health care system. A complete overview is missing. And we need a change in the organization and reimbursement care to ensure the availability of quality of nutritional care within the public health insurance system. The documents for this modification of the DRG system is already prepared, and the same for the update of nutritional care performance unit of doctors and dietitians. So we have three main problems to solve and work on it. DRG codes cultivation, actualization of coding of medical performance units, and recognition and reimbursement of the work of a dietitian in the ambulatory sphere. And I'm really happy that Ministry of Health gives us voice and hears on that what we are able to work together. And the same for the insurance companies. What we learned from Europe. Progress in addressing malnutrition in hospital, outpatient setting and the population. And this can be achieved only with cooperation. So getting together professionals, patients, politicians and industry. I think that we have successfully completed this stage. The solution to this problem is in the hands of an alliance for nutritional care that unites all stakeholders, and the identification of patients at risk of malnutrition will enable early preventive treatment. It is always more effective than late intervention. And the role of medical professionals is to define the problem, the role of politicians and to define the problem, the role of politicians is to enforce appropriate legal measures. So putting the hands together and work together in one problem. And what can we give Europe? To fulfill the right to nutritional care and accessibility, to work towards goal, raise knowledge and awareness of disease-related malnutrition, to support clinical nutrition education and research, respect ethical principles and values, enhance patients' empowerment in diagnostic and therapy, and working together on a local, national and international levels. So, thank you for your attention. Thank all the online participants. And I believe that the topic will be open for discussion later. Thank you.
Thank you very much. It was very illuminating. And now I have the pleasure of introducing our next speaker, the Minister of Health, Professor Válek, who gave the auspice to this event. I would like to welcome him on the stage with a few remarks, and the floor is yours, Mr. Minister.
Thank you very much. So, first of all, ladies and gentlemen, let me apologize that I am late, but, you know, government is government. Nutrition is important, but to lead a state, it's a little bit more important. So, allow me to welcome you here in Prague, as well as those of you following us online. I am delighted to have given me patronage of this event, which is also held under the auspice of the Czech presidency of the European Union Council. We have a unique opportunity to highlight the importance of nutrition and nutritional care as an integral part of healthcare. So, and this is also a little bit personal for me because I am a radiologist. When I started 35 years ago as a doctor, the most important nutrition for me as a radiologist was barium enema. Barium enema we use for patients which need some better improvement of small bowel and so on. And I started my first publication together with Professor Mařatka, which was extremely famous Czech gastroenterologist, expert concerning nutrition, perhaps teacher of some of you. And my first publication was about transit time at patients with different small bowel disorders according different nutrition. So nutrition is my personal things. Now, before I start to be Minister of Health, I was professor of radiology and my specialization was interventional oncology. In fact, I established European Society of Interventional Oncology with colleagues from France and Italy. And therefore, I'm personally very pleased that my co-speakers will also address the topic of nutrition in oncology. Oncology is an extremely important issue. Cancer care is a priority for the Czech Republic and the Czech presidency. And we know that optimal nutrition is essential in treatment cancer patients in order to maintain their quality of life. patients with cancer suffer from malnutrition. It's clear. And nutrition and correct nutrition treatment is important before majority of surgery the patients with cancer. So it is our job to ensure early intervention to prevent these negative consequences related to the patient with cancer and bad or low nutrition. Therefore, we really take nutrition and nutritional care seriously in the Czech Republic. I am pleased that the Ministry of Health and the State Institute of Public Health have a well-established and functional cooperation with a leading expert from the Alliance for Nutrition Care. The cooperation is really close and excellent. We also strive to include the patients, and we have a unique platform to do that. The Ministry of Health has a special project called Patients Hub. This project, the reason to have this project is to improve the patients' organizations in policy as well. A major change which we have been working on in the Czech Republic since 2019 is the upgrade of the hospital food and nutrition care system. And I think this project is extremely important, and it is closely related to quality of care to each patient in Czech Republic. In September 2020, the Ministry of Health issued the national standard for hospital food and nutrition care. And we continue with this project. We want to improve the quality of nutrition. There are some colleagues from my university. Nice to see you. And there is a lot more I could talk about, and there is also a lot of work ahead. We know that ensuring access to quality nutrition care is a long-term process, but we also know that it is extremely important. Please use today for inspiration and get contact to cooperation, because it is a key for countries to work together to implement European Union recommendation for optimal nutrition care. As without proper local implementation, European Union programs will not benefit the patients. I promise that all your suggestions, all your recommendations I will deeply support, and I wish you fruitful discussion, fruitful meeting. If there will be some post-meeting dinner, then good wine. And on behalf of the Czech Republic, I can say that we will do our best to promote the topic of access to nutrition care at the European level, and I will advocate that our college continues this important work during the Swedish presidency. So thank you for your attention and good luck, and better nutrition in our hospitals by our patients. Thank you.
Thank you so much for your remarks. I wanted to ask you if you would perhaps consider coming to our round table, Mr. Minister.
Yes. Don't worry.
Will you join us for the round table discussion?
With great pleasure.
Great, thank you. So please take a seat, and I would like to invite our previous speakers to join us here at a round table where we will discuss what does it take to integrate nutrition into our health.
Pane profesore, já vás taky.
Úžasná akce, super. Jo, to jsem rád, krásný den. Děkuji.
Thank you. Yeah, you too.
Pardon. Dobrý den. Hello, nice to meet you. Great pleasure. Ben, dobrý den. Děkuji. Nice to meet you.
Thank you. So please take a seat. We'll take a seat with you. And the format that we would like to work is that I would ask each of you a question. Anybody on the panel, please feel free to follow up. And then we will take some questions from the auditorium. Great. So let me start with you, because you are the closest. Thank you so much for your introductory words. I understand that we are now in the middle of the Czech presidency. And in terms of nutrition, how do you think that the Czech ministry can help to secure nutritional care that we see right now on the EU agenda? Is this something you work with?
I think the nutrition and nutrition therapy is a very important part of European agenda, but of course it is impossible to finish this agenda during our presidency, but we want to support and continue this discussion with Swedish presidency. I think it's necessary to define what is the keys of our agenda, and this oncologic treatment. And it is clear that it's necessary to have widely available rare drugs, orphans and centers for oncologic patients. It's extremely important to have standardization and availability of screening programs and to build a cooperation between different centers in different countries concerning oncology and concerning treatment. And it seems to be, if you think about this very important big topics, because transplantation, surgery, oncology, nutrition. So if you discuss about these big topics, then the patients is the most important part of this discussion. And without good quality nutrition and nutrition therapy, is impossible to offer to oncologic patients, and therefore it's important that oncology is part of this, and discussion about nutrition and nutrition treatment, the therapy at the patient with oncologic and cancer diagnosis is important. So without nutrition and nutrition treatment, is impossible to offer good quality center treatment, good, very expensive biologic drug, individual therapies, main surgery, transplantation. So I want to start, and I would like to start discussion about nutrition. Nutrition, like radiology, is not independent. It is part of all other medical procedures, all of other specialization. And because oncology is most important issue, and this is the answer finally, I apologize, I was so long. Nutrition and nutrition therapy is also very important issue during our presidency. So this is what we can do.
Mm-hmm. You also mentioned standardization in your opening remarks, and once again here, is this something that the ministry supports, standardization in nutrition? You mentioned the guidelines for hospital care, but also for social care and other areas. Is this something?
Definitely, we do that. We started to discuss with colleagues from other Ministry of Agriculture, Ministry of Education, concerning standardization, concerning high quality, and I hope we will introduce to our Parliament some legal changes, some changes in our laws, and we will also discuss, as we want to have same standardization concerning screening, concerning treatment protocols, so we want to have same standardization concerning nutrition in different European countries. Generally, the political idea, if we have Europe as a one country which support Ukraine against Russia aggression, if we want to travel between these countries, we need to offer European citizens same quality of care, same quality of screening program, and of course same quality of nutrition. And without standards, it is impossible.
Thank you so much. Very interesting. Dr. Cieszyński, the ONCA campaign supports European countries in their aim to implement nutritional care in policy and practice by sharing good practices among each other. Could you share some key learning in developing the Czech strategy?
Absolutely. I just showed in one slide that we learned from the European ONCA the strategy how to develop the way of standardization of nutrition in hospitals, the standards for diagnostics of malnutrition, and how to approach the education in the field of clinical nutrition. And this is what we just apply, and we have to do it in our way. Yeah, I love being a part of Europe. I'm really happy about this fact. But on the other hand, every part of Europe, every nation, every state has specific features for everything. For nutrition, I cannot compare, for instance, German cuisine with French or Mediterranean. So the specificity of individual members of European Union have to be taken in account. But on behalf of that, we are able to formulate guidelines or recommendations which may be applicable as general standards with the option to add some specific details for the specific nation, land or country. So this is what I mean. In terms of education, even more, it's good to make the system of education similar in every country, so that one day we are able to achieve a European certification in clinical nutrition for doctors, for dietitians.
You mentioned the local features of standardization. Where do you see ONCA's role in this, and do you think it should play a role, or who should be the sort of stakeholder and leader of the process?
I think the type of organization which is ONCA is absolutely important because it takes together multi-stakeholders. I don't like the word, but it is so. I'm a doctor from an academic sphere, and I also have outpatients and patients in an intensive care unit. But I'm able to communicate with politicians. I'm able to communicate with the insurance company with the help of my friends and colleagues. And ONCA, and in Czech circumstances, APNP, Alliance for Nutritional Care, is able to put all these parties on one stage. And by this way, it is when we communicate, we are able to find a primary goal and the targets how to get success on it.
Thank you so much. Docent Novák, throughout the morning we heard about DRG, we heard about costs and the financial pressure that is on the system. Where do you see the role of nutrition in terms of necessity for the cost? Do you think that we can see it as an investment rather than a cost?
It's difficult to talk about investment in terms of health and nutrition, of course. But yeah, I take this comparison for granted. I think, as I've already mentioned in my short introduction, nutrition care has been already proven as a cost-effective medical intervention, and as such, it carries cost, but it saves in terms of reduction of complications, reduction of length of hospital stay. And of course, it offers a great advantage in terms of quality of life, and that's something which is also important. And we are currently learning how to express quality of life as a relevant endpoint, measurable also in economical terms. because it's important when we compare such expensive interventions like biological treatment in oncology, and it's I feel it pity if we have such a relatively cheap intervention with high effectivity, and we are not promoting it enough. It's also true who should be responsible for its promotion, for education, for informing patients how important not only nutritional therapy but also in combination with physiotherapy, as we've already learned how important it is to have proper nutrition with physical activity as the tool how to improve functionality and how to improve quality of life. So I think we have everything in place, and we are just about to cooperate to make it happen, I suppose.
From your perspective, who do you think should be the leader of the implementation of translating what we already know at the level of hospitals down to the primary care and to other sectors of healthcare?
I think each stakeholder has its own responsibilities. Definitely, with respect to the guidelines, it should be scientific societies. Like I think lots has been done on the side of Aspen. We have not only scientific guidelines, but we have also practical guidelines. So it's much easier for all specialties. Today we are concentrating on cancer beating plan, but remember, nutrition is universal, or malnutrition is universal negative prognostic factor. So nutrition is important to all other specialties. We should start with those specialties where it is really important, where the impact of malnutrition, not only oncology but also geriatrics, maybe neurology, with especially neurodegenerative disease and gastroenterology, surgery, where we have guidelines in all these specialties. So, yeah, I think that's the responsibility of us nutritionists, both physician or dietitian ones. But today we are also talking about responsibility of patients as well. Mm-hmm. So I think it's also if we are able to provide education, if we are able to provide tools, it's as we are all potential patients, we are all citizens, and that's why I think it's our responsibility to take this information and to work with. In order to promote health and to decrease healthcare costs. Otherwise, we are not going to pay for all needs. We must save, and we must be responsible.
Yeah, thank you. Definitely agree. Mrs. Malíčková, you were active in the European structures of patient organizations. So from your experience, when does it come to awareness and expertise among EU policymakers on nutrition and intestine failure? What could be the avenues to explore to enhance the quality of policies at the EU level, or do you think they're sufficient?
Oh, that's quite a difficult question.
No easy ones here.
Nobody has got the easy question. I think it all comes down to communication, talking to all the stakeholders and all the parties that are engaged in creating policies. I think the situation is improving at the moment, and more we patients are brought into these various discussions so that we can give our point of view. And as I said, the main interest for patients is to have the best quality of life possible. I see the patients and I know them on like personal basis, and I'm interested in how they deal with their day-to-day life. So I think the communication between patients, the policymakers, and the doctors or the medical specialists is important. So let's keep communicating. Let's keep exchanging information as well, because there is a big potential for educating the patient as well. And again, for this, we need to have good communication channels between the medical professionals, so that we can learn what is actually possible at the moment, so that we can be aware of the best equipment, best services, or best medicaments, and so forth.
Thank you so much. Professor Laviano, you've touched upon the latest on nutritional care science, and your pre-speakers have spoken about it too. Where do you see the bottleneck when it comes to implementation of the latest science?
The major problem that we face is that, again, we have the recommendations, national, international guidelines, but the problem is the implementation is a major problem, because there is a lack of education in medical school. So, and everyone believes is an expert in nutrition, and so say, and you know what they say? Okay, I'm eating 3 times a day. I'm an expert in nutrition. It's not the case. This is not the case. Nutrition is one of the major metabolic modifiers we have. So it really can make a difference. Of course, we are being taught about the drugs which have a time to clinical benefit of few days, and maybe nutrition has a more extended time to get beneficial, which means that you have to start as soon as possible. And I was so enthusiastic to hear the passion of the Ministry of Health in advocating the role of nutrition, because from the, let's say, Italian taxpayer perspective, I think this is what I would like to see from my politicians, someone who is working to change the current sick care in a health care. So the ministry has to work on improving the health, not to treat the disease. Yes, of course, definitely. Yes, of course, treat the disease, definitely. But to improve the health, which means that you have to implement programs, as you are doing here in the Czech Republic, in order to improve the quality, for example, of nutrition across different stages of the life of a citizen here. Not only, I would say, patients, but also the lay people. Because unfortunately now we are extending a little the issue of cancer. In 10 years, the healthcare system will not be able to support the aging population, the retired population. So I think this is really important. So we unfortunately miss a generation of doctors who are not expert in nutrition or do not anything in nutrition. So we are now building a new generation, and I can tell you that the new generation is really more receptive of this concept. But again, I'm not saying that all doctors should become expert in nutrition, but they should be aware that the problem exists. It's like saying, the engine of my car is smoking. I cannot fix it. I send to one which can fix it. So you have to learn that there are screening tools validated, and if there is a problem, you can forward your patient to someone who is an expert in that. Because nutrition is not only using olive oil or butter, but actually is to adapt the nutrition to the needs of the patients.
Thank you so much. Mr. Minister, you had a comment?
Yeah, we established it is 25 years ago with Riccardo Lencioni and some colleagues from Italy, oncologic indication board. And there are different members of this board. I don't know why it's not nutrition therapist or nutrition expert member of this board, because if I remember, before I was minister, discussion during our oncologic board in University Hospital Brno, there was a repeated question, what about nutrition? There was oncologists, there was gastroenterologists, there was nuclear medicine specialists, surgeons mainly have such a question, radiation oncologists, radiologists, but nobody can answer this question. How look these patients? We discussed about the Hirsch index or other indexes, but we didn't discuss about nutrition. Could be one of the next steps in Czech Republic that nutrition expert, nutrition specialists have to be member of oncologic indication committee.
Absolutely. I think it would be a great idea because, and I also liked, if I may, highlight what you, Minister, said about the standardization. And I think that at the European level, we have to recognize that saying outcome, the ultimate outcome measure is survival, to say if a treatment is okay, should be adapted. Because I would agree that if I am a patient with a stage 1 cancer, I would say, okay, survival it's my ultimate. But when you have a patient with stage 2, stage 3 advanced disease, maybe survival is not really the ultimate measure. As you were saying very nicely, the patient, particularly with those with a chronic disease, and in some cases cancer is becoming a chronic disease, they deserve a good quality of life.
I'm sorry that I interrupted, but you are absolutely right. There's a lot of disease. Typical example is Crohn's disease or ulcerative colitis, when nutrition is more important, like only treatment. What is a better quality of life related concerning to patients with Crohn's disease? Good quality of nutrition. We can offer long-term survival, but in fact, in a lot of cases, with low quality of life, because we cannot offer good quality nutrition. I mean, it is clear and easy.
I fully agree.
Yeah, definitely.
May I comment on this? I think that the problem of contemporary medicine is super specialization. I'm an internist, and I'm not talking with a cardiologist. I'm talking with an echocardiographer. I'm talking with an intervention cardiologist. The same for oncology, the same for gastroenterology. And the super specialization is a risk of ignoring the patient as a integral personality. The patient is in the diagnostic process, and from a GP to a otorhinolaryngologist, and to a pneumologist, then to neurologist, etc., etc. And there are still super specialities within these specialities. I can see it, for instance, in a patient who is indicated for therapy for a tumor in the oropharyngeal region, and I will appreciate a colleague, a otorhinolaryngologist, who gives me a call and asks, well, Mr. Smith is being planned for therapy within 1 month. Could you do some preventive measures, some prevention, so that we know that after 6 weeks he will not be able to swallow anything, and we can prepare the patient. This is a valuable and a perfect cooperation between the medical specialties, but unfortunately it does not work always. Alessandro, you mentioned a problem with the engine. If I have my engine smoking, so first of all, I have to recognize the problem and then send my car to be repaired. And the same for the patient. I have to put a name on a problem. Then can I do that? If we are able to do this, we are on a good way.
Yeah, you're right.
Absolutely. Thank you so much. And
may I have a short comment? I totally agree. We have so many specialties, but we've already agreed that nutrition is quite universal patient or human need. I'm sure we will talk about later today. So whom should be responsible? I think we need to go to primary care, as all patients successfully treated in hospital return back home, and we need continuity of care. We need to establish cooperation. I know it's very difficult as primary care physicians look after so many things. So nutrition may be one, but let's make it for them easier, and let's show them how important it is, and that they really are the candidates to look to individual patient and to really guide the patient throughout all the specialties of healthcare system.
Mm-hmm. I would like to add that maybe engaging more the patient organizations is also important, because with all respect I have for all the doctors, unless you have the medical problem yourself, you will never know what it's like to live with it. I think it's very important that the patient organizations reach for the patients, and also that the doctors or the medicals, the nurses, they try to tell new patients, or even the old ones, but especially new patients, that these organizations are here and they are able to help them. Maybe not on the medical side of things, because that's what the doctor is there for, but to help them with the day-to-day life, what it's like to live with this disease or with special needs that everybody needs for day-to-day life. I think that, again, that's one of the levels on which we need to work on a bit more.
Have you ever thought about institutionalization? Thank you. Of patient organizations as a part of, as an official part of healthcare practice or life science?
Yes, we have, but to be perfectly honest, when you say patient, that means that you have a lot on your plate. So it's very difficult for us to put a lot of energy into achieving something without the help from the outside. So if I was to say it in very plain English, we, the patients, the sick people, we need a lot of help from the healthy people who have more energy, more time, more knowledge. So we can, although we can do a lot, we are still interdependent on other parties as well.
That's right. Do you have any more comments from the speakers here? Then I would like to ask our esteemed guests if they have any questions they would like to ask. Oh, thank you.
Hello. I would like to make a comment at first. I'm also a patient, but I'm a patient from Poland, so I drink this barrio meal quite often. But first of all, I would like to congratulate the organizers for a great event, which is an inspiration for us also to create a similar one, the Czech Society, but also European Nutrition of Health Alliance. But first, mainly, I would like to thank you, Minister, for being here, for your presence, which also stress the importance of the nutrition. I'm also a patient who is dependent from the parenteral nutrition, but generally the nutritional support. And that's something what I dedicate my life for. But without your support and without the knowledge or also the understanding from the authorities, I won't be able to help anyone else. Also, you mentioned a lot about the quality of life. That's very true, the same as all of the presenters. But that's not only our quality of life, but also the quality of life of our families. I have a kids family, so the way how we're supposed to live will impact also our surrounding. There is one more aspect which I would like to draw, and then there will be a question afterwards that you mentioned also about the cancer treatment and the importance of the nutrition, which is quite close to you. It's not only a matter of the quality of life, but also the drugs works completely different when you you are malnourished. So therefore, that there are really expensive drugs. So therefore, that's also worth an effort to draw interest into the nutrition, but also malnutrition when we consider a cancer patient. But taking into account the question, I would like to also ask you, how do you engage the patients into the policy-making process? Because I heard that you mentioned something about the patient hub, but yeah, is there any structure for engaging the patients also from the nutritional point of view? Thank you.
So, thank you for your comments and your question. So, I mean, it's extremely important to involve patients' organizations. So, I give you some example from Saturday this week. On Saturday, we will organize in Brno, not we, but patients' organization, Crohn's disease with celiac disease, because it is malnutrition syndrome, some of the malnutrition syndrome, national meeting. I cooperate with this organization very closely. And I will be there. I will introduce how to investigate small bowel with ultrasound and how to do early detection of celiac disease with ultrasound. And chief of these organizations are members of some patients committee in the Ministry of Health. This patients committee is chief of this patients committee from Ministry of Health is Vice Minister for Law. And he's responsible to communicate and cooperate with these patients. We also opened the hub. It was not my responsibility. It was Wojciech Adamo who was the first. Wojciech opened, my previous minister opened this hub, and I continue with this work because we closely cooperate with all past Minister of Health. Majority of them are my friends, even if they are from different political parties. So, and in this hub, they communicate different representatives of patients' organizations, patients with diabetes, with Crohn's disease, with different disease, and they have some suggestions and some recommendation and requests focused to Minister of Health. And we try to answer their question, we try to fulfill their request, and there is some budget on Minister of Health office. We also a little bit this budget, not so much. I'm not sure if it is financial minister here or some of this department. So, but and my idea is to support deeply these patients' organizations, not concerning nutrition, but concerning, for example, telemedicine. It is crazy if a doctor discuss what need patients concerning telemedicines. It is much more easy to ask patient, what do you need? And then offer this. So I agree with some speakers that we are professionals, or you are professionals, expert, we are subspecialists. I am radiologist, but I am not radiologist. I am interventional radiologist. I am not interventional. I am onco-intervention radiologist, but unfortunately non-vascular onco-interventional radiologist. Blah. So, but we are only free in Czech Republic. Nevertheless, we are also service. And patients, all population, are our customers. If you want to offer good quality service, good quality shoes, good quality suits, we first of all have to ask customers, what do you want? What do you want? What do you need? And then you can fulfill patients, customers' expectancy. This is a reason why we have this hub. This is a reason why we discuss with patient organization.
Thank you very much. There is one more. You asked the question how to raise the topic of the nutrition at the European level. So we need to have more Ministry of Health in different countries, like Professor Walek. So please tell your Polish colleague how important nutrition issue is.
Be sure there is a lot of such a Ministry of Health. German Ministry of Health is epidemiologist, great guy concerning pancreatic carcinoma, early detection of pancreatic carcinoma. 30 years ago, we organized together, when we was younger, some prospective study concerning early detection of pancreatic carcinoma. There are also gastroenterologists from Holland. It is gastroenterologist guy, which is Minister of Health. So there are 5, 6, 7 doctors. We discuss very deeply. Also a colleague from Slovak is doctor. So we discuss very deeply the issue. And I think the situation changed very fast because COVID is a big problem. But we learned a lot during the COVID, that cooperation, communication and very open and deep discussion with our customers, with patients, is important. Many bad decisions which was done during the COVID from different European politicians was because there was not enough discussion between politicians, experts, and population, patient. And we have zero interest to repeat these mistakes. We discussed during our ministerial meeting in Prague, September this year, very deeply and informally this issue, and I promise I will continue this discussion for this year and next year during Swedish presidency as well as.
Thank you so much. Do we have some other questions from the public?
As it is recorded, it's better to speak on microphone. My name is Jan Goida. I'm from 3rd Medical Faculty. I'm very appreciate the talk and the seminar we had today. It was very nice. And I have a small comment, and the question follows afterwards. We now have a very nice guidelines on organization of the nutritional care in hospitals, which is pretty much a nice example how we can approach the problem, because we know very well how to feed the patients, and put in our guidelines the concrete step is very important, but the organizational part of the whole thing is usually a bit more blurred. But it is this part that actually in the end helps us to communicate with the insurance company. To give another example from my own perspective, I currently work as a member of Czech Diabetes Society on an update of the guidelines on nutrition in diabetes patients. And there we want to implement also this part of organizational, how to organize the care of nutritional care in the patients with diabetes. It means that how often they are about to see the nutritional therapist, how they take care of them, what is the difference in between different approaches. And we have a huge body of evidence how to feed our patients, how to take care of their nutritional needs, because there's so much of the evidence. But the evidence and actually the implementation is about the organization, how to organize it all. Who is the first line therapy, who is the second line, etc. And then we end up with in a state, and now we'll soon get to the question. We end up to the state that we find out that we do not have a sufficient amount of these field soldiers. If we want to battle malnutrition, also in the sensu lato, malnutrition is also obesity and the complications of obesity, not to forget. So we need the soldiers, and the soldiers are nutritional therapists. And nutritional therapists... dietitians, if you want, yeah, nutritional therapists or dietitians. If we want our patients in ambulatory care, outpatient departments to see nutritional dietitians or nutritional therapists, then you need to have them. And then what I think where we still need some support in the Czech Republic, that is education, elevation, and bringing out the excellence among dietitians, meaning that we have associate professors, we have professors in this specific field, and these will then elevate the whole state up. Because as I look among here, we do not have any speaker from this state within the board, which only reflects the fact that we still have a long way to go, so that we build excellence in this field. So I would like to. So that is educational part. So that is my question: whether this body or whether somehow ONCA strategy also focuses on supporting this nutritional or dietitians state education, so that we can then use it within the organization of our nutritional care. So that's it.
So, who has the courage?
Yeah, if I may. Well, we tried using. I would use the process of the guideline. The hospital food and nutritional care in hospitals guideline. We actually clearly stated the number of dietitians in hospital per number of beds. And we also found that the number of dietitians who are allowed in the process by hospital managers mostly, but as we are in the reimbursement scheme of DRG in the hospitals, it's mostly on insurance companies' reimbursement policy as well. If the reimbursement per case in this scenario, if it contains dietitian's care appropriately, and that's why we created proposal for cultivation of DRG with respect to special coding of dietitians units per patient to be reported back to insurance companies, so they know what they are paying for. And as well, we need to have signaling codes with respect to malnutrition diagnosis. We have GLIM system, but we still are waiting. As a matter of fact, Swedish professors are really in advance, with especially Professor Sederholm. They created initiative to change international coding of disease nomenclature with respect to modern diagnostics of malnutrition. So we in advance proposed signaling codes respecting this system. So hopefully we are able to promote it, and also there is another point. We need outpatient clinics of dietitians to be allowed to get into the system, because I think it's crucial. Maybe that's one point how to help primary care physicians, because if they start to pay attention to this problem, they really need somebody to refer to the patients with if they are willing to detect the problem. Otherwise, they are not going to take it, because I mean, why to screen if I'm not able to intervene on the level of primary care? So who should be able to do it than dietitians, I suppose.
If I make a short comment on that, you know that ESPEN is a multi-professional, multidisciplinary society. We are collaborating with EFAD, which is the European Federation of the Dietitians. So there is definitely a great collaboration between these different specialties, and the goal is the same for me. I'm a doctor, for the dietitian, for the nurse, and so on. Now, it always happens that if a general manager of a hospital has a limited budget, he prefers to hire a new cardiologist rather than dietitian. But I mean, this is a matter of culture, and we are responsible for the culture. I mean, we have to be very proud of what we are doing. In my country, for many years, the head of the clinical nutrition units were the surgeons who failed as a surgeon. The gastroenterologist who failed as a gastroenterologist said, okay, you're not a good gastroenterologist, let's go and head the unit of clinical nutrition. So we have to change this approach, because by doing that, we have to be strict on the guidelines. Because when we say the patient has to eat 1,500 calories, we have to be strict on that. Because if we are not strict on that, we demonstrate that we still do not believe in nutrition. Mm-hmm. I mean, on this planet, if a patient should receive 10 grams of an antibiotics, nobody would say, hey, 10 grams of antibiotics, come on. That's 5, we save money. But the majority of our colleagues, when we say they have to take 1,500 kilocalories a day, and they actually give 500 kilocalories, we don't say anything. So we need to be strict on the guidelines, because we have to show them that nutrition is not how to usurp olive oil or butter, but it's a therapy with the same dignity, with the same evidence as all the major disciplines, and without saying anything against the other disciplines, which are very much important, but it's absolutely has the same dignity, the same evidence, the same importance for the patients.
So let me very short comments because time is here and it's not necessary to be too so serious. So first of all, you mentioned that the decision concerning the DRG and so on is done by insurance. It is only partially true. It is done by me.
Okay.
So if you have any suggestion or recommendation, I will do that with great pleasure. If you want to have new code, it is easy to do that. It's necessary just only contact my office and to prepare official proposal, and let's do it. Simply easy.
Okay, for granted.
Yeah. I was surprised a couple of months ago when I started to be Minister of Health that I am law. But in fact, it's true. So, second, concerning diet. I think if the patients compare quality of different hospitals, they compare if the nurses are polite and nice and how good is food. Nothing other is interesting. And it is starting higher and higher number of directors and managers in the healthcare system to recognize these two problems. It starts to be growing but it is not closely related to nutrition, but it is partially related to nutrition on to diets. So it starts to be more and more important issue. And of course it is long-term process. It is old history, but I will very briefly explain. When appeared Euratom in Europe, Spidla was our commissar responsible for healthcare, and I was something like his advisor with Professor Caramello from Italy and some other colleagues concerning Euratom. And the idea was that in each hospital will be a radiation physic, which will control the risk of X-ray and so on. The interest between managers, between directors was zero. The interest between radiologists was big minus. Between nuclear medicine experts, radiotherapists was big minus. After 20 years, it is 24, 22, you perhaps remember better as I. Now we have in each European country Euratom as a part of national law. There are radiation physics in each European country as a supervisors, and X-ray protection, how to reduce X-ray doses. It is one of the most important issue for companies, for doctors, for different specialists, even if not for all specialists. For neurologists, it's only a small problem. But it starts to be a very important issue. And I mean, we can expect same future concerning nutrition. It is clear because your presentation, your answers, your discussion, it is true reality. And it is clear how important is nutrition therapy, and diet. So, and therefore, I'm very optimistic concerning future.
Thank you so much. Thank you for your comments. Thank you, dear panelists. So I think that in summary, we should focus on improving our quality of life, and of course start working on the standardization, and you will get the proposal in a few days. I'm sure.
Definitely.
Thank you so much. We'll resume for lunch, and then we will be back at 13:20.
My dokonce už je máme v systému, takže...
To, co je potřeba změnit, už jste mají úhradovou vyhlášku na příští rok.
Nejenom, že mají tam jdeme mikrofon. who will have a lecture on opportunities of Europe's Beating Cancer Plan for patients. Professor Svoboda is director of Masaryk's Institute of Oncology in Brno. With clinical and scientific focus on breast, colon, and rectal tumors, oncological genetics, and prevention. Thank you. The floor is yours.
At the beginning, I would like to say that I would like to thank organizers to inviting me for such forum. The nutrition is very important in oncology, as the nutrition status is one of the basic predictors of the cancer treatment outcomes and also a predictor of the quality of life of the patient. So it's really very important for us, and thanks again that I can speak here. My speech today will be about to introduce you Europe's Beating Cancer Plan and the opportunities for patients coming from this plan. So maybe you know that cancer constitutes one of the worst health challenges in the EU, and in Europe accounts for 1/10 of the world's population, but 1/4 of the world's cancer cases. And in 2020, 2.7 million people in the EU were diagnosed with the cancer, and another 1.3 million people die for cancer. And the number of cancer survivors is growing every year, and we estimate that over 12 million in 2020. And also increasing the cost of the cancer in the EU. So without conclusive action by 2035, cancer cases are estimated to increase by almost 25%, making cancer the leading cause of death in the EU. So, and moreover, the COVID-19 pandemic has had and will have a severe effect on cancer control, delaying diagnosis and treatment, disruption prevention, and also have a negative impact on the lifestyle. And EU responds on these challenges, and the Commission introduced on February 3rd, 2021, Europe's Beating Cancer Plan, which is a policy document defining a strategy and actions against cancer and mobilizing the collective power of the EU and member states' efforts for this struggle. European Beating Cancer Plan will be implemented using the EU financial instruments with total about 4 billion euros, and which will be being reserved for the actions against the cancer. And one of the most important instruments will be a mission on cancer. The general objective of the European Beating Cancer Plan is to accelerate progress in cancer prevention and control programs, creating fair access to these programs across the EU, and strengthening support for patients and families. Regarding the mission on cancer, the general objectives are improving the lives of more than 3 million people by 2030 through prevention, cure, and for those affected by cancer, including the families, and to live longer and better. The European Beating Cancer Plan is structured around the 4 key action areas: prevention, early detection, diagnosis and treatment, and improving on quality of life. And those areas have 10 flagship initiatives and multiple supporting actions. The flagship initiative on the first 2 flagship initiatives are on to research, innovation and digitalization. The first one is to create a knowledge center on cancer to help coordinate scientific and technical cancer-related initiatives at EU level and diffusing best practices, which is very important, implementation and issuing guidelines to feed the design and roll out a new action under the European Beating Cancer Plan. The second is to launch a European Cancer Imaging Initiative to develop an EU atlas of cancer-related images and making them accessible for data analyzing using high-performance computing and artificial intelligence to improve personalized medicine and innovative solutions. There are also other supporting actions, like, for example, using the health data space, the European health data space, to create some kind of integrated format for the patient's history, which could be used and shared using these electronic health records. The third flagship initiative is on saving lives through sustainable cancer prevention. It's eliminate cancers caused by human papillomaviruses through EU support for member states on vaccination, with the aim of vaccinate at least 90% of the EU target population of girls, and a significant increase the vaccination of boys by 2030. There are also other supporting actions, but you know the vaccination is the most effective one regarding the prevention, the primary prevention. So the other supporting actions are improve health literacy on cancer risk by updating the European Code Against Cancer, create a tobacco-free generation in Europe when less than 5% of the population will use the tobacco by 2040, reducing at least by 10% the harmful alcohol consumption, and also the propose the mandatory front pack nutrition labeling to empower the consumers to make informed about the healthy or the risk of the food they choose. And the other, of course, and that's very important regarding the nutrition, because we know that about 40% of cancer cases could be avoided through the prevention, and if the citizens can reduce the prevalence and the citizens can reduce the prevalence and burden of the cancer by, for example, living healthy diet, physical activity, reducing obesity, vaccination, reducing exposure to chemicals, and the others, of course. The fourth flagship is on the improving early detection of cancer, and it's devoted to develop a new EU cancer screening scheme to ensure that by 2025, 90% of the target population is offered breast, cervical, and colorectal cancer screening. So it will be not only about the ensuring the new strategy, how to get such a high number, but it will be also about optimizing the existing population-based screening programs, for example, based on the new biomarkers, those biomarkers who come from the genetics, like, for example, the polygenetic scores, or from the lifestyle of the patients, like, for example, about the obesity for the colorectal cancer. And also it's about to provide the options to extend the screening to a new cancer, such as, for example, prostate cancer, which is now very frequently discussed on the EU level, screening of the lung cancer, which is now a piloting in many countries, also including the Czech Republic, and also others like gastric or pancreatic cancers. And also to develop new guidelines and quality assurance schemes for screening, diagnosis, treatment, and rehabilitation follow-up. The fifth and sixth flagships initiatives are focused on ensuring the high standards in cancer care. The fifth one is to establish an EU network of comprehensive cancer infrastructures, linking recognized national comprehensive cancer centers and infrastructures in every member state, but unfortunately not all member states has such infrastructure, to improve access to high-quality diagnosis and care by 2025. And the cancer plan, again, aims to ensure that 90% of eligible patients will have access to such centers by 2030. And this is also important regarding the nutrition, because the screening and assessment of nutritional status must be a standard of care in such comprehensive cancer centers, and appropriate nutritional interventions can reduce cancer-related complications and comorbidities, so also the education regarding that must be introduced in such cancer centers. The sixth flagship initiative is launch a cancer diagnostics and treatment for all. This is an initiative which will optimize cancer diagnosis and treatment and reduce unequal access to personalized medicine in cancer care. This approach will use the NGS technology for genetic profiling of tumor cells, allowing these centers to share cancer profiles and applying the same of single diagnostic and therapeutics approaches for patients with comparable cancer profiles in all the EU member states. The seventh flagship initiative is on ensuring the high standards in cancer care again. It's the third one on the topic, and it's a launch UNCA activity. The YUNCAN activities is a program which is driven to increase of understanding of how cancer developed and facilitate personalized approaches to cancer prevention using the polygenic risk scores techniques. And in this particular case, it's actually the first call which was already closed from the Mission Cancer program, and Czech Republic is a part of this consortium which is defining the YUNCAN program. So it will be about, and some other supporting actions regarding these high standards in cancer care are focused on ensuring a high-quality health workforces. And again, this will be also focused for the training of the healthcare workers, and will also include a focus on patients' quality and well-being, including the mental, psychological, and nutritional support. And again, from the view of the today's topic, which is nutrition, healthcare professionals should be educated on the risk of malnutrition and the importance of optimal nutritional care to optimize the clinical outcome during the therapy. So the 8th flagship initiative is on the topic of improving the quality of life for cancer patients, survivors, and carers. And it's launched the Better Life for Cancer Patients initiative, including the Cancer Survivor Smart Card and the creation of virtual European Cancer Patient Digital Center to standardize and summarize patients' clinical history. It's very important from the clinical practice. We daily see the patients who haven't know about the treated history, and then it's very difficult to work with them and account what will be the late effects of the late toxicity effects from the cancer treatment, and improve the patients' and health professionals' communications and coordination around the patient medical follow-up, especially management of late and long-term effects of the treatment, as I said. The 9th flagship is on reducing cancer inequalities across the EU member states. And it's a launch of a cancer inequalities registry to map trends in key cancer data, identifying inequalities between member states and regions. So a number of indicators show that there are major differences in cancer prevention, for example, and care between and also within the member states. Also in the Czech Republic, we see some areas, for example, the border areas or rural areas where the access to the prevention or to the most innovative care is not such perfect like in the areas which are in the central Bohemia or Moravia or around the big cities. And these inequalities can be seen in access to prevention program, as I said, in rates of early cancer detection, diagnosis, treatment, survival, and measures to improve quality of life cancer patients and survivors. And these inequalities are unacceptable on the European level. So these registries are supposed to help to find such inequalities and to give to the country some country-specific tools which could help to improve such inequalities. And the last flagship initiative is on putting childhood cancer under the spotlight. And the launch is to helping children with cancer initiative to ensure that children have access to rapid and optimal detection, diagnosis, treatment, and care. In such case, Czech Republic is a very good example of the practice because we have just 2 comprehensive cancer centers which are focusing on childhood cancer, and 99% of our childhood cancer is centralized to such 2 centers. Other supporting actions are to establish the EU network of young cancer survivors, and this network will strengthen the long-term follow-up in cancer care plans at national and regional level. It's very important because our young people, they are very often not only commute, but also change the place where they live, and they go abroad, and so it's very important to have such kind of network, the clever card, which they will use it for sharing the history of the disease, and where they will have written the plan of the treatment and plan of the follow-up. So, the implementation of the European Beating Cancer Plan is an important topic during the presidency of the Council of the EU, and all the presidency countries, they pass these topics to the next countries and discuss it together. So, for example, during the French presidency, France started with the cancer meeting on the February. It was the first expert meeting during the presidency, and they focused on pediatric cancer, poor prognosis cancer, cancer prevention, and right to be forgotten, and international cooperation. We were involved in the planning of their presidency, and also we have discussed what could be the topics which we will do and which we will focus during our presidency. And as the friends, we also, one of the first meetings which we organized under the Czech presidency, under the auspices of the Czech presidency of the Council of the EU, was an expert conference on oncology, which was organized in Brno in mid of July this year, and was focused on comprehensive cancer infrastructure, future of cancer registries and the European health data space, and improving early detection of cancer and screening schemes in EU. So that's a picture from the conference. And last week we have organized the largest cancer conference, national cancer conference, which was a Brno Oncology Days. And we again had two main topics under the auspices of the Czech presidency of the Council of the EU. It was focused on precision medicine, pediatric oncology, and patient-centered cancer care and survivorship. Thank you for the attention.
Thank you for your contribution. It was very interesting. Now I would like to ask Dr. Jiří Horecký with his keynote on the new European Care Strategy, a platform for nutrition, joint approach at global scale. Thank you, and please.
Thank you very much for the invitation. Good afternoon, ladies and gentlemen. I'm presenting the European Aging Network, and we have different activities also towards nutrition care. Now in the long-term care sector and elderly sector, I would like to present now. Sorry that I couldn't attend the morning part of the conference, but I had a chance to listen to some of the outputs and allow me to present you the view of some of the European experts in the elderly care in this sector. First, I would like to introduce the European Aging Network. We represent 10,000 care providers in whole Europe from 26 European countries. We are an umbrella association, so our members are by 80% the national umbrella association, by 20% the big chains or big private providers. For-profit, not-for-profit, and also public through the associations. And our role is within the civil dialogue to be the voice of the long-term care providers in Europe. We have different activities. We are trying to enhance the quality of care. We are trying to advocate for all the challenges and problems that we are challenging in long-term care, like the staff shortages, like the underfunding and the not sustainable funding models. And we introduced in 2019 a report that was a result of 2 years' work by European experts. This report is called Long-Term Care 2030, so it's basically our vision. What changes are we undergoing? What changes are we have to provide to have also in 2030 what is called in the 18th principle of the European pillar of social rights, so that the long-term care is affordable, accessible for those that are in need also in the next years to come. So we also open the discussion about the paradigm changes and also about the quality of life, which we see nutrition care is and must be a part of. It was also translated into 3 languages, and it's to download. You can download it at our website. The other report that we introduced last year is the taboos and prejudices in long-term care. So we, once again, with a group of experts from 6-7 European countries, try to identify the biggest taboos and prejudices in long-term care. Once we started working on that, we realized that it's not only in long-term care, but it's the biggest taboos and prejudices in aging generally. So we identify 4 taboos and 14 prejudices, and some of them were also reflected in the COVID-19 lessons learned. That some of these prejudices we could strongly see during the pandemic in the long-term care sector. And then the last report that I'm going to present in the next slides is promoting well nutrition in elderly care, because elderly care and nutrition is one of our main topics, and we didn't just end our activities with this report. And I have to say, none of these reports were done within some European projects, because I see so many European projects and you just apply for the money and then you have to write something to meet the indicators. So this was something that every year we take part of our membership money. We pay the traveling costs for the experts that are meeting on a regular basis and are working on these reports or recommendations to meet our main goal, to enhance the quality of care and quality of life. If we talk about long-term care, I would like to just mention a few of the changes in this sector that we see in most of the European countries. In some of them, the changes are accelerating in a more rapid pace. In some of them, they are slower. So we see that the hospital model of nursing, the hospital model of nursing homes, has been changing, and we can see it especially in the German-speaking countries, in the Nordic countries, that it's more a movement from the health or hospital model to the social model and to the holistic approach of care. We also see that nowadays generations and the future generations are looking more not only a quality of care or nursing, but the quality of life and all the services that are linked with long-term care, also with housing, with food, with nutrition, with a free time structure. And we can also see it in the Czech Republic that still the people that we have in nursing homes nowadays, they look more at the price and not a quality of what they get, but people that are going to be there in the next 15, 20 years, so people that are now 65 plus, 60 plus, they are more looking on what's quality and more than what is the price. And of course, you have to have social protection tools to enable them the long-term care services. The nursing homes and long-term care providers, so it's not only residential care, we are also talking about semi-residential care and home care services. They turn into facilitators, into coordinators of the care, more than just solid providers of long-term care sector. And also we can see the transition from a curative nursing home model to a modern service center. It's also very often that it's not only one services, but it's a range scale of services that are provided. And we also see that the providers are aiming at prevention within their organization for their clients, but also for people outside. So we also see, and this is something what was mentioned as one of the conclusions, that nutrition is now becoming a very important part because we are more talking about quality of life than quality of care. In the last decades, it was always quality of care. Now there is a more holistic approach, talking not only about the care. This is only one part, maybe one smaller part, but to talk about quality of life. And if you talk about quality of life, the nutrition is a very important part. It's maybe one example for that. We, in the Czech Republic, we created in 2011 a quality mark, which is an assessment tool and that gives the public feedback what is the quality of life in these nursing homes. In the Czech Republic, there are 125 certified or accredited, let's say, nursing homes. And once we created them, we created 300 criteria in 5 sectors: housing, eating or nutrition, care, partnership, and culture and free time. And then we appointed points or some value to these criteria as experts in the field. And we asked 200 seniors in 7 regions and get the feedback, and we had to change our, let's say, assessment. We thought that, for example, the housing and for leisure time and culture is important for the people in nursing homes and in assisted living for seniors, but nutrition was one of the most important topic for them, and they give us this feedback. So we had to change the criteria system. So because we realized that it's an important aspect of quality of life, we started a working group and the goal was to create a report that would be an everyday tool or instrument for the care providers to help them to deal with this important aspect and part of the care. So that's why we invited not only the care providers, our members, but also nutritional experts of EAFAD, the European Nutrition Association, and also industry. We started this working group. It was not easy because we started, I think, in February 2020, and then it was COVID time, so it was not easy to continue meeting. But at the end, we succeed with that, and we had also follow-up action on this report. We didn't want to have it too academic. Like I said, we wanted something that would be practical, that could be used in everyday work, in the kitchen, in the management, in the nursing parts of the homes. And also we wanted to give some practical points to the staff. And also we realized that the situation is very different and may differ from Greece to Sweden to Ireland and Czech Republic. So it was, and we had experts from I think 7 countries, and there were like Sweden, Greece, Belgium, Austria, Czech Republic. So it was also interesting to see how this working group worked. We managed to translate it into 7 languages. Czech is one of them. I have the English version here, and I will, after I finish, I will leave it here, and the fastest one can get it. And it's also been translated because people want it in our languages. So, for example, we got a question from Senecura, Austria. And Senecura has also some 14 nursing homes in Czech Republic, whether they could translate it into Slovenian and Croatian languages, because they have 1 or 2 facilities there. So that is also a feedback from us that it's important for them to get it translated, even though they have very few organization there. Here you can see some of the pages, and we are going to have 1 or 2 more translations of them. What are the main points that are in this report, and what were the main points that was the result of our activities? There are different relevant aspects of malnutrition of older people. We ask ourselves what are the main reasons that malnutrition still exists in the nursing homes, in some of the nursing homes, in some of the long-term care facilities. What are the determinants? What are the main causes for that? And having said that, we try to discuss and open what are the preventional tools and mechanism to prevent the malnutrition in long-term care facilities and settings. Who should be responsible for identifying the solution to malnutrition? It goes from the kitchen to the nursing part. In most of the European countries, you have social part and the health nursing part apart from each other, and they have different competencies also. So that was also one of the issues that we discussed. Then the best ways to tackle malnutrition for older people and for care providers, and how to provide some guidance on awareness raising of problems that are or more levels in the nutrition care in long-term care facilities. What are our next goals? First, we wanted to get it translated and to disseminate it. Then we finalized some follow-up action, and that was a survey that was done in 4 countries: Spain, Portugal, France, and one more, Netherlands. Thank you. And we also organized roundtables to get a feedback what in those countries are the biggest obstacles, challenges in nutrition. So that is also something that we did as follow-up plan from this activity and report. We are realizing that there are blurring boundaries, like I described them a minute ago, that mal and malnutrition, it's not only the medical issues, but it's a complete and holistic approach in the nursing homes and long-term care facilities, that we have to connect more levels of management, more levels of experts that are taking part of the whole care in the process. We realize that it's not only a matter of health and social care, and this is something that we would like to also point out and extend for the future, that eating is a social act. It's something that makes people happier during the day. It's something that we should more respect also their behaviors and their needs and wishes on that. So to not to offer them some ideal life at the end of the life in these nursing homes, but also accept something that we may consider not very healthy, but it's important for them to meet their wishes and goals of that. Good food is a joy, and preventing is better than curing. So that is also something that goes beyond just the nutrition. That the eating is broader than that. It's not only a matter of cooking and eating, and it is also economic aspects. So that's why we are also mentioning the food waste and food waste management also as one of the aspects that are important. And this is something that we are also facing now in most of the European countries, since you know that the food is becoming more expensive and more expensive, and you have some regulation settlements. Oh, that's a very great example in the Czech Republic, what we have to face in March this year, because we have some limits to which we can buy food for the elderly, not only in nursing homes, but also once they get the Meals on the Wheels, the home care provide them with lunches. And because this limit was not changed the last 8 years, what happened, and we did also some survey from that, is that the nursing homes stopped using meat and the expensive food. They slowly started cooking from cheap food and components, and also the variety of food was lower because of these regulations. So the economic aspect, especially today, is very important and should be reflected in the funding models and regulation models of the long-term care settings. We understand nutrition care for older people not only as the medical issue. It's more a social or even a human issue. It's a part of the whole approach and environment of older people. It is changing, and we should accept that also with the real nutrition care. The preventing role I've already mentioned, and the last thing and last slide I would like to present is also how to get where we would like to be to meet our goal in nutrition care. We see nutrition care as actually as a human right, because there is a right to health care, there is a right to have food and not to be in poverty, not to starve. And if you connect these two rights, the result is a right to nutrition care. Not only within the wall of long-term care facilities, of course. And there are a lot of relevant policies and platforms and opportunities. One of them is the European Care Strategy that was released the 7th of September this year. If you read it, there is not one word about nutrition and food. Like, these words are not particular in the report, but the approaches and how you tackle the whole system of long-term care, it's there, and the accent to the quality of life and self-determination is very strong in this care strategy. And there should be 27 action plans, because every member country should create this action plan, or was recommended to start an action plan on long-term care. And we have also the message from our ministry that also the Czech Republic is going to present the action plan till the end of 2023. Then we have the other platforms like the European Parliamentary Alliance Against Hunger and Malnutrition, EP Interest Group on Obesity and Health, System Resilience, European Nutrition for Health Alliance. The European Beating Cancer Plan was just presented a couple of minutes ago. We have also a lot of actions that try to extend this, tackle this topic, like Nutrition Awareness Weeks, Nutrition Day, or the Aspen Vienna Declaration. What we try to do from our umbrella view is to give the information, good practices examples, and some inputs to our members at the national level to encourage them to give this information to the grassroots level, so to the everyday care providers, and then get the reflection back to us and to other relevant platforms and stakeholders in the care or long-term care sector in Europe. So this was just a brief introduction what we do in terms of well nutrition and what are our goals and our intentions for the next months or years to come. Thank you for your attention.
Thank you so much. It was a really interesting point of view that I think we haven't heard so far. And I have a question for you. And the question is, the aging population is not constant as we are, unfortunately, growing older. Do you perceive some changes in terms of how the group of older people reacts to nutrition, malnutrition? Is there any development? Is there positive development?
Generally, the quality of care and the approach is changing, and also people are demanding more. And we see it not only in the Czech Republic, we see it in the whole Europe. The long-term care settings are very different. So we have countries where the state is relying very strongly on informal care, and it's just happening in the families, and there are not so many health instruments. And we have other countries like the Norwegian countries where it's vice versa, and they have very strong capacities of all the services, and the share of informal care is the smallest in Europe. And also, if I'm saying that if you compare it, then you can also see the changes about the nutrition care as a part of long-term care. So it's more the developed countries than the countries where the capacities are very low. But the approach is changing, not only the approach by the governments, but also the providers. They are more looking at the quality and not quality of care, but they are looking at quality of life. That's also a discussion not about food and nutrition care, but also housing and all the other services that are connected. And it's more patient or client-oriented care. What is also now in a process is to overcome from patient-oriented care to patient-led care. So it's actually the older people or the patient's clients that are leading or having a strong determination on how the care and the life should look like.
I think it's a great message. Thank you so much.
Thank you.
Thank you. And now I would like to welcome Professor Diana Cardenas-Bras, the professor of medicine, who will give us a lecture on nutritional care as a human right, a joint approach at a global scale. If I could ask you to.
Yeah, of course.
Thank you.
Thank you. Hello, everybody. I would like to begin by thanking the organizers for inviting me. I'm really happy to be for the very first time here in this beautiful city of Prague. I think that it's a very good opportunity to talk about human rights in clinical nutrition. So I would like, the aim of this conference is to analyze how the application of the human right-based approach to the specific field of clinical nutrition can contribute to the construction of an ethical political framework to the concept of nutritional care. And here I need to say that nutritional care must be understood as a process that includes screening, diagnosing and assessment, the administration of medical nutritional therapy, this means parenteral nutrition or supplements, and monitoring. And I will focus my presentation on to understand how this approach, that I consider is a global approach, mainly through the Vienna Declaration, can be very useful for a local implementation. I think that after listening to the conference during the day, I'm convinced that this approach can help to bridge the gap between policymakers and scientists, and this approach can help also to promote a more based approach, or patient-centered approach. So, the world is facing an emergency. There is 768 million people undernourished. And moreover, hunger affected 46 million more people last year than in 2020. And there is a total of 150 million more undernourished people, or people suffering from hunger, since 2019. And this is not only because of COVID pandemic, because the upward trend in hunger begins before the pandemic. So this is even more worrying, as we know that there is a continuum, a continuity between community and the hospital. And if we know that there is around 800 million people undernourished, the good question will be what's happening at the hospital, what's happening in the clinical context. And we know that in this field, the specific field of the clinical context or at the hospital, we have disease-related malnutrition. This is a specific type of malnutrition that cannot be explained only because of the lack of nutrients or food, but also because of inflammation and metabolic perturbances. We know for different studies that the prevalence is around 50%, and we know that the impact of this type of malnutrition is very important on outcomes, and also we know that there is a very important economic burden for this type of malnutrition for the health systems. The prevalence of nutritional risk factors has been studied with the Nutrition Day data. I like very much Nutrition Day data because this study allows us to, in one day, have a picture of how nutritional care is being doing in different institutions. So with this data, the Nutrition Day team allow us to know that there is a very high prevalence of nutritional risk factors. Here in this figure, we can see the prevalence of malnutrition risk represented by dots, and each dot represents 1% of the population. So what I want to show you with this figure is that the nutrition risk factors are present before getting to the hospital, and they're still after the hospital, and the impact of malnutrition, of nutrition risk factor, have been quantified, as we can see here, an odds ratio very important for the death. So interventions are different in the community and in the hospital. All the interventions in the community are focused toward food security, and at the hospital, intervention is focused toward nutritional care. This means screening, assessment and diagnosis, medical nutrition therapy, and monitoring. So we have, as it had been said during the whole day, we have a very cost-effective therapy that has been proven in different studies. We know after the effort trial that a systematic approach to patients with nutritional risk factors is associated with a decrease in short and long-term mortality. We know also that nutritional therapy
for medical. I don't know what's happening with my micro. That's it? It's better like that? Okay. So we know also, oh, it's so loud. We also know that nutritional therapy for medical inpatients is a high cost-effective intervention. Should I continue or should I stop? Okay. It's me? I have too much good waves. Okay? Okay, so I was saying that, as we already said during the day, we have nutritional therapy is a cost-effective therapy, it's a cost-effective intervention. And it has been proved in different studies. Here I have the results of the EFFORT trial that show also that nutritional therapy for medical inpatients is a high cost-effective intervention to reduce risk for ICU administration and hospital-associated complications while improving patient survival. Despite the fact that we have this cost-effective intervention, nutrition care processes are never done in more than 50% of the patients. So this data from the nutrition, they allow us to know that it's very important disparities among nutritional care access to in patients. So we know, as we have been also discussing during the whole day, that we are facing important challenges to fight against disease-related malnutrition. And structured approach to tackle these challenges needs to include and involve stakeholders to implement nutritional care process. And it needs also to promote continuity of care after discharge from acute care hospitals. And in this context, we need, and we are convinced that the human rights-based approach can be a global strategy for local implementations. So the good question now is, why do we need a human rights-based approach in clinical nutrition? We know that there is intervention at the community level that looks for, that are based on action and plans considering food security and food insecurity. But what's happening in the clinical and in the hospital context, what's happening with nutritional care interventions? We know that disease-related malnutrition is not targeted by the Sustainable Development Goals and is not part of the agenda of the United Nations Decade of Action. Particularly the SDG 2, Zero Hunger, that looks to eliminate all forms of malnutrition. Disease-related malnutrition is not included, is not targeted by this SDG. So this has very important consequence at the national and local level. Policies addressing this type of malnutrition are lacking, and this has very important impact, mainly in the lack of reimbursement schemes, the lack of responsibility person or team at the hospital level. There's limited awareness on this problem, this lack of education of healthcare professionals. There are missing empowerment of patients and family, and this has had very, very important ethical implications. So, as a summary, why do we need a human rights-based approach in clinical nutrition? We know that there is an intervention that is cost-effective, and people are not getting them. People are not receiving nutritional care. So we are not respecting the fundamental ethical principles of beneficence, autonomy, and justice. And we are so not respecting the dignity of the human. And dignity here understood as the intrinsic value that all we have only for being human beings. So this is where this human rights-based approach is very useful. So I'm convinced that in these times, these very particular times, in Europe you have a war, and we need to believe in the power of human rights-based approach. And the very first article of the Universal Declaration on Human Rights of 1948 states that all human beings are born free and equal in dignity and rights. However, we know that we are not equal when it comes to different human rights, as the right to food and the right to health. So we need to be convinced that this is not an utopical thing. Human rights are concrete. Human rights are for real. And human rights reflect the minimum standard necessary for people to live with dignity. So that's why a couple of years ago we decided to create an international working group with some friends from Latin America and Europe, Rocco Barazzoni, Isabel Correa, And we decided to create an international working group to study the link between clinical nutrition and human rights, and also to explore how the human rights-based approach can contribute to the challenge faced by the practice of clinical nutrition in increasingly demanding healthcare system. So we invite other experts from different societies, from the American Society, from ESPEN, FELAMPE, PENSA, and from Africa, from the South African Society and the West African Society. And we invite also other experts in different fields, experts in human rights, experts in history, experts in pediatrics, etc. So we have been working within this group, and we published 2 papers. The first paper defined nutritional care as a human right, and we consider that this nutritional care should be considered at the intersection of the right to food and the right to health, therefore creating good opportunities for the implementation of legislation, policies, and programs. And very important, we need to know that this human right should be, the basis is the respect of human dignity. And it's important to distinguish between the right to food and the right to nutritional care, as in the field of public health and in the political context, the beneficiary of the right to food is considered to be a person with an active role to which the state must provide an enable environment to enable him or her to feed himself. On the contrary, in the clinical context, in general, in the clinical setting, the sick or the ill person has the right to receive a nutritional therapy. This means to be fed, and this implies an expert or at least a team in clinical nutrition. So the impact of this human right is different for the different actors. For patients, this is, they need to know that they have the right to benefit for the whole process of nutritional care. This means screening, the right to diagnose, etc. For clinical nutrition practitioners, dietitians, doctors, etc., they have the duty to assure optimal and timely nutritional care with the respect of dignity. For scientific societies, they have the duty to promote nutritional rights as a human right. And for government, for policymakers, we think that they are bound to respect, to protect, and to fulfill the right to beneficiate from the whole process of nutritional care. So in a concrete way, the fulfillment of the right to nutritional care requires mandatory actions, including nutrition screening and hospital admission, and during the first clinical contact in primary care. Second, the diagnosis and assessment of malnutrition in all at-risk patients, and provision of a regularly monitored nutritional care by oral diet or evidence-based medical nutrition therapy. And in order to promote this, we decided to write or to propose a document that we call the International Declaration on the Human Right to Nutritional Care. This document was approved by ASPEN, ESPEN, FELAMPE, and PENSA, and it was there endorsed and signed by 75 international societies around the world. And this declaration was signed during the last Congress of ESPEN in the city of Vienna. This, very briefly, this document is a non-legally binding document. This means that it implies a moral commitment that sets out a shared vision and principles for implementation of the right to nutritional care, and is grounded on the international instruments of human rights and bioethics. The aims of the declaration, I will only be fast because we're going to have a small video that will repeat all this information, but the aim is mainly to promote the recognition of the human right to nutritional care, to provide a frame of reference whose principles serve as the basis to the development of actions, and very important, to define core values, goals, and principles, and of course raise awareness of this problem. So in the Vienna Declaration, we have 5 solid principles. These principles told us what we need, but they don't tell us how to do that, how to translate this, what we want into concrete actions. So these 5 principles of the Vienna Declaration are related to public health policy, to improving education and research, to ethical principles and values, to institutional culture that evaluate nutritional care, and the patient empowerment. So these principles tell us what we want. And the next step, and we are working on that, is how to translate these principles into concrete actions. So for us, these local actions should focus on development of policy, education and research, ethics and institutional culture, and patient empowerment. As a matter of an example, and to finish, the first principle said that public health policy must make fulfillment of the right to nutritional care as a fundamental axis in the fight against disease-related malnutrition. And to advocate for evidence-based policies and practicing disease-related malnutrition, we are looking to develop a policy brief to just bridge this gap between the policymakers and the scientists. And in this way, we hope that we can put in the international and in the national agenda the problem of nutritional care and the disease-related malnutrition. So some key messages to take home. Very important, I think that we need to consider that nutritional care is a human right linked to the right to food and the right to health. The second message is that we need this approach because it could guarantee human rights principles, values, and standards that made real in the clinical practice. And this approach to clinical nutrition could contribute globally to the construction of an ethical, political, and legal perspective to the concept of nutritional care. And finally, this approach, this global approach, should be considered as a tool to allow local implementation of nutritional care access for all persons suffering from disease-related malnutrition. We have, if you can please put the video.
The International Declaration on the Human Right to Nutritional Care. Disease-related malnutrition is a frequent condition caused by virtually any acute or chronic disease, with negative impact on a person's quality of life, increasing comorbidities and mortality, and prolonging hospital stays, thereby resulting in unnecessary healthcare costs. Although it is increasingly clear that nutritional care is able to effectively prevent or treat malnutrition, and to improve disease prognosis and outcomes, access to nutritional care is still unacceptably limited to most patients. This means that most sick persons worldwide do not benefit from screening, diagnosis and assessment of malnutrition, neither from administration and monitoring of medical nutrition therapy. That is why ASPEN, ESPEN, FELANPE, and PENSA have committed to promote and defend the recognition of nutritional care as a human right. On behalf of all members of the 4 major international societies in conjunction with a global network of national societies, in the city of Vienna in Austria during the 44th Congress of ESPEN, the International Declaration on the Human Right to Nutritional Care is proclaimed. Although this declaration does not have a binding legal effect, it has an undeniable moral strength. The declaration recognizes that access to nutritional care is a human right intrinsically linked to the right to food and the right to health. It sets out a shared vision and principles for implementation of the human right to nutritional care in all patients with disease-related malnutrition, in all settings and conditions. Respecting the right to nutritional care may contribute to benefiting from other human rights such as the right to health, the right to food and the right to life. The Vienna Declaration is grounded on the international instruments of human rights and bioethics. The FELANPE's Cartagena and Cancun Declarations, the Universal Declaration of Human Rights, the International Covenant on Economic, Social and Cultural Rights, the Declaration of Bioethics, the ESPEN and ASPEN documents on ethics, among others, which provide a solid basis for its principles. Principle 1. Public health policy must make the fulfillment of the right to nutritional care a fundamental axis in the fight against disease-related malnutrition. Principle 2. Clinical nutrition education and research is a fundamental axis of the respect and the fulfillment of the right to nutritional care. Principle 3. Ethical principles and values in clinical nutrition, including justice and equity in nutritional care access, are the basis for the right to nutritional care. Principle 4. Nutritional care requires an institutional culture that follows ethical principles and values and an interdisciplinary approach. Principle 5. Patient empowerment is a key enabler to necessary action to optimize nutritional care. Through these principles, the Vienna Declaration seeks to protect those at nutritional risk and malnourished patients. These 4 international clinical nutrition societies, together with many more, are deeply convinced of the need to appeal to public authorities, international governmental and non-governmental organizations and other scientific societies on the importance of optimal attainable nutritional care for all patients. Thus, we launch a global call to unite in fighting malnutrition and respecting the right to nutritional care.
Learn more, share the declaration and help us to defend and promote the right to nutritional care.
Thank you so much, Professor. It was really interesting to see this, I would say, groundbreaking legal concept. And I have a question for you. The fifth principle mentioned patients. And how would you say that the patient can advocate to be involved in this concept? And how can they maximize the impact of the initiative for themselves?
But first of all, I think that they must be aware that nutritional care can be considered as a human right. And second, I want to say that we need to invite them to work with us in this action plan that we are working on, because we will have a specific tool that will look to include into existing patients' charters. We need to include nutrition care as a human right. So first of all, I will say be aware of, and we will invite them to work with us.
Thank you. And one other question. You mentioned that the convention is structured as a basic human right. So do you anticipate that there will be liability issues for patients who are malnutrition, because this will be seen as their human right, which in the care could be breached if they are not nutritioned according to the standards, for example?
I'm not sure if I understood the question. Could you please?
Yeah, you mentioned in the concept that it's a basic human right, and as a human right, there is a concept of liability. So if I'm not nutritioned rightly, my right was breached, and there is someone liable. So do you think that there will be disputes over this, that this will actually end up being a legally enforceable right?
But not at this time. We are only as the very first time proposing, but we hope that governments should develop nutritional care access, and that will be a legal basis for that. We are not claiming that patients need to be forced by feeding. We are not saying in any case that we need to feed any patients at any cost, even while dying. No, on the contrary, we are saying that we need to know when not to feed. Mm-hmm. What we are saying is that we need to, governments promote the access to nutritional care. So if someone is not giving nutrition support or nutrition therapy, there is maybe a reason, and it's not including the doctor decisions.
Okay, thank you so much. And thank you for the presentation once again. And now I would like to invite our next speaker, Mrs. Martina Parísková, the representative of the Ministry of Health, who will give us some remarks as to initiatives that the ministry has in plan in nutrition. Thank you.
Thank you very much. Good afternoon, ladies and gentlemen. My name is Martina Parísková, and I'm here to speak for the Czech Ministry of Health. And after the beautiful and excellent lunch that we had, I don't want to take too much of your time and just show you some of the nice pictures and best practices that we've been trying here to implement, to bring to the Czech Republic. As you could hear earlier today from the Ministry of Health, Professor Válek, the Czech Ministry of Health really takes nutritional care seriously, and to do so, we are extremely lucky to have a support of excellent experts. We work with the best. The Ministry of Health has the support of the National Institute for Public Health as another public authority, but then we have all the experts on nutritional care under the Alliance for Nutritional Care. And then, as was also mentioned earlier today, we also want to bring in the patients, and for that the ministry has a special project called the Patients Hub. And the major and groundbreaking change here in the Czech Republic that we've been working on basically continuously since 2019 was the national standards of hospital food and nutritional care. We presented the details at the ONCA website, so you're free to look it up and consult the details, and also the colleagues here are more than happy to tell you every single detail. but I would like to show you that we are really bringing something new and something special to the hospitals. We are encouraging hospitals to introduce 2 basic diets. One is a basic diet in health, and one is a basic diet for patients at risk of malnutrition. And here we have a beautiful example from our General University Hospital that is running a big pilot project implementing the national standards. And they have a beautiful cookbook, which I might also use at home maybe for some of the recipes they are bringing the patients. And then this is also new, that we are really trying to empower the patient, and we are providing materials for the patients to educate them about their dietary options while in hospital and then also after discharge. And what is new, and we have seen some good experience with, are choices of meals by the patients. Then very important, what we are trying to show here is that malnutrition screening has become a part of standard procedures at hospitals, or if it has not yet, we are trying to introduce this into the system. So basically the standards, what they are trying to do and what they set the basis for is to strengthen the system of nutritional care in the Czech Republic. And also this quite action picture is from the University Hospital in Plzeň, where and in many other hospitals throughout the Czech Republic, we have invested a lot of money, and the hospitals have invested a lot of money to make the kitchens super modern. Hospitals are investing also in excellent chefs and really motivated personnel. And really what I have seen throughout these years is that we are working with really motivated people who are really the motor of this change, and really they are running the whole thing just through their internal motivation. So how we are trying to strengthen the system. We have the standards, we are trying to implement them, and we recognize as the ministry, and our minister here today supported that we see the importance of nutritional care. We know it's economically beneficial to have good nutrition, optimal nutritional care introduced. What we have identified and see as extremely important is to empower the dietitians, to increase their role in the system, and we are really right now trying to implement a legislative change and increase their presence in patient care. And as we could again hear the minister say today, we just got some homework to do. We got some work to do on DRG cultivation and work on that. And we need to, similar to updating the standards of hospital food, we need to also work on updating medical treatment procedures. But working on the nutritional care in the inpatient sector is not enough, we believe, and I'm sure we all agree on that. We are, as the Ministry of Health, but also in cooperation with the Ministry of Agriculture and other public authorities, working on the area of strengthening the system in public health in general. Just to give a brief example, there was a lot of work done on food safety and nutrition strategy 2030, and it has, as you can see, two objectives: food safety and also nutrition. And on the part of nutrition, I would just like to highlight that there is immense amount of work put right now into improving the system of school meals and nutrition. And the ministry also provided some standards for nutrition in schools, which every single school canteen in the country should have at hand and use in everyday practice. So just to conclude, and we heard it many times today, our cooperation between EU member states is really vital and essential in order to bring proper nutritional care to our citizens and patients. And we, as the Ministry of the Czech Republic, as our minister said, we will make sure that this work continues, not only on our national level, but also on the international level or EU level. So thank you very much for your attention.
Thank you very much. Thank you for the input. Now I would like to ask Docent Novák to give us a few concluding words, and afterwards we would have a short panel discussion with the panelists.
I'm just waiting for concluding slides. Well, we've heard quite a lot today. Well, as a matter of fact, this is something which almost in the same setup scenario happened 13 and a half years ago during last Czech EU presidency, where the conference regarding fight against disease-related malnutrition and diseases due to malnutrition was held nearby Prague, and also giving some remarks to next EU presidency, which is again Swedish. So let's look at today's conclusions. Using excellent work of Professor Cárdenas Bras, we think that main conclusions, let's use the word Prague Declaration out of this seminar, might be in these points: nutrition risk screening, next step, proper nutritional assessment, and of course nutritional care based on proper dietary intervention, and only if this is not sufficient or not possible, implementing medical nutrition on an evidence-based approach. And we also think that the human rights-based approach should be considered as a possibility for local implementation or for facilitation of local implementation of nutrition care access to all persons, to all citizens, as we have in the title of today's seminar. And we also believe, after such a fruitful exchange we had today, that pan-European collaboration is capable of acceleration of implementation process of optimal nutritional care on a local level as well as across the countries. And using or having this opportunity of discussion in between the Alliance of Nutritional Care, let me pass this Prague Declaration to Ministry of Health, just to be further passed to next Swedish EU presidency, just to go on, and maybe in another 3.5 years we will resume what happened and what shall be happening in the future. So Thank you very much for your attention. I think we still have some time for panel discussion. We have still esteemed speakers here present, so I think we can discuss what are the possibilities of further development in the Czech Republic and maybe also in other countries.
For all the work that has been put into it, and we will make sure that it will be passed on the Swedish presidency, and the work will be carried on. Thank you.
Okay, so thank you very much for cooperation.
Super. Thank you so much. I would like to invite our panelists. So, Professor Svoboda, Dr. Horecký, Professor Diana Cardis-Bras, and you. I'll take my usual space. Okay, thank you. Thank you, everyone. So I will start with you, Professor.
Of course.
My first question would be, in terms of the framework that you prepared, what is the next step? What do you plan to do next? What do you plan to build on what you started?
This is a very important question, I think, because with the Vienna Declaration, we just said what we want. Now we want to translate those principles in concrete action. So now we need to work on a toolkit that allow us to real transformation in the local settings. So now we are working on that, and this is an ongoing process. So we are working on tools, and you are all invited to participate in that. We will send information very soon about this.
Yeah, I'm sure that there will be great interest from ONCA. Would you like to add something to that?
Yeah, I think this is really interesting principle, and I think it may help in solving the problems we are really facing, especially with respect to two situations like we today heard experience from patients on parental dependent on parental or enteral nutrition. They clearly without nutritional care have problems to survive. But there is also another field we solve the problems, and it's palliative care, because not all patients in palliative care proper have benefits from the full nutrition. I think with just right to nutrition we can't solve this problem. So I suppose we really need this expansion and this combined approach using nutritional care as a human right may be of help. So that's what I think. It's still in the process of development. I think it will be really interested to get feedback, because now the Vienna Declaration was kicked off, and I think we should wait what strike it's going to make, what will be the response from the general public. I think that's something which is meant not only for us as nutritional professionals, but mostly for people out there, I guess.
Yeah. Do you think that this will impact, of course, also your work, or it's too early for that?
It will and it should, because it's we cannot if we talk about the right to nutrition, we cannot just separate one group of citizens, one group of people. We cannot concentrate just on hospitals and healthcare, but we have to go beyond. So it's a very strong instrument to use it in what we are doing. We are talking a lot of that long-term care should be accessible and affordable, but we must have discussion what we mean by that and what should be in the structure of the long-term care. And that's a good incentive to promote nutrition in this sector.
Can I say something? I need to say that we need that every society that signed the declaration appropriate this declaration. This means that make their own. The declaration has no authorships. The declaration is out there to be useful for everybody. So every society, scientific society or any organization can have it and can transform the principles into actions. That's the idea of the declaration. So we need that every society make their own initiative, as yours today. It's an excellent example of what we can do with the declaration. But we are proposing from ESPEN different actions. We hope they will be global, but this is really a global initiative to be applied in national and local context.
Thank you so much. I have a question for you. And you spoke about aging citizens. Do you think that you're getting enough support from the EU or from the national perspective, or is there something that you would like to see being improved?
We can see in the last 5 years that long-term care and aging has become a very important topic. It was not before. Maybe it kind of started with the European Pillar of Social Rights, that we can see that long-term care is enshrined in 6 of the principles, more or less. And then it started with the Green Paper on Aging, which was, I think, 2019. But was never approved and published, but it was one, and the aging reports also in 2018. So from that period, it started, and European Commission released the long-term care report, and now it's the EU care strategy. I think it was also as COVID-19 reflection, because we saw that the long-term care sector was overlooked and underfunded and neglected, and so that was also one of the reasons. And now the concentration of the European Commission is there, and then really would like to enhance the care, not only care for people with disabilities and older people, also for care for children. So the care strategy is the care for the 3 main groups: children, people with disabilities, and older people. But indeed, it has become a very strong topic in the last 5-6 years.
Thank you. And last question for you, Father Docente. So in terms of the conference, you have the presentation with the outcomes. So what will be the first thing you do in terms of strategy or policy when you start discussing what happened here? What do you think is the key takeout, the first thing that you will act upon?
Oh, I'm quite excited. We had well, you've seen the discussion we had with our minister. Actually, he was very, very open, and we proposed 3 main areas to work on, and actually he asked us to give proposals as soon as possible. So I'm really excited about this, and I think that's with respect to our local activities, it's a major advancement. I must admit that I was not hoping for such a open offer of cooperation, and I also hope that this some example to other ONCA countries and to those of you who participated online, and yeah, I think this is very nice conclusion of this meeting, and that was exactly what we were hoping for.
Thank you so much. Now that we have a few minutes left out of our time, are there some questions from the public? If there aren't any questions, I would like to thank all panelists. I would like to thank the organizers and supporters for this event. And I hope that we can see each other earlier than in 14 years when we have the presidency again. Thank you. Bye.